You can improve your surgery score today without memorizing more facts, just by recognizing how sick the patient is. When I was an intern at Harvard MGH, attendings drilled one lesson above all others. Know instantly when you should run or walk to a patient's room. In other words, how sick the patient is should determine how quickly you are going to ambulate to the room. This same principle unlocks surgery shelf questions because management always depends on severity. The sicker the patient, the more aggressive or urgent the intervention. The more stable the patient, the more conservative the approach. In part 2, which is what you're watching right now, I'm sharing content from our paid course showing exactly how honors level students assess severity to get more questions right immediately. Not necessarily by knowing more content, but by recognizing which patient can wait and which one can't. There was a student recently that I coached who she jumped from like a 225 to a 257 in about 2 weeks. And one of the things that she learned in the time that I was coaching her was how to use principles to get more questions correct. And so this was one of the most common principles that people struggle with, is that, like, I had a student once who he thought, okay, in this one diverticulitis question, I got this question wrong because they said that the answer was take them to surgery. But in this other question, I said take them to surgery, and it was also a diverticulitis patient. The answer was IV fluids, IV antibiotics, and NPO. I don't understand. Diverticulitis question, surgery. Diverticulitis question, and, conservative management. I don't understand what the difference is. What he was missing is that in the case of the patient who had to be taken to surgery, they had a lot of signs of severity. So they were being brought into the emergency department. They had shock vitals, so they had a low blood pressure and a high pulse. They also had signs of end organ dysfunction, right? So their urine output was low despite getting, bolused with fluid. Whereas in the other case, the vitals were completely fine. They had no signs of end organ dysfunction, right? They were mentating fine, meaning they were getting adequate blood supply to their brain. They were not having any problems with their kidneys, right? Because their urine output was fine. And so again, even though the diagnosis was the same, the severity was different. And so what you want to do in general when you're studying is that you want to find principles that you can use across many different scenarios. Because I'd say the most common issue for people when they're studying management questions, which for step 2 and shelf exams can make up to 40% of your test. The most common mistake that I see people make is that they think, oh, okay, for management questions, I have to memorize the specific scenario. I need to know all of the sort of up-to-date level sort of algorithms so that I know exactly what I should do in every single scenario. Now, the challenge with that is that not every scenario is going to map perfectly with what it is that you learned. And if you try to memorize every single possible variation of scenarios, you're going to end up with a lot of things that are going to get jumbled together in your head. And so instead, what's better is to try to find a principle. So this principle of if they're more sick, then you're probably going to do something that's more urgent and more invasive. And if they're less sick, then you're going to do something that's less urgent and less invasive in terms of management. It can help you immensely. And so for the rest of this lecture, what we're going to do is I'm going to teach you some basic content. So this is from our paid course. You're going to see some of the content from our paid course, and you're going to learn some high yield principles. You're going to see this principle of severity mapping to management in real time. So enjoy, and be sure to leave a like, subscribe, and notification. Hey, so before we move on to the next concept, if you want to go deeper on these and other high yield topics, we have a free 14-day course that covers exactly what it is that we have found help students go from, in some cases, failing all the way to 260 plus. So be sure to click the link in the description to sign up. I'm going to show you the vignette. I'm going to read it so that if you're in the car either now or later, you'll be able to hear it. And then we'll go through the pathophysiologic chronology. So I'll read it first. A 29-year-old man is brought to the ED 30 minutes after being found unresponsive on the floor next to an open bottle of barbiturates. Examination shows diffuse movement to painful stimuli. He is intubated and mechanically ventilated. Creatinine is 4.7 milligrams per deciliter. What is the pathophysiologic chronology? So again, I'm going to put this into the Google Doc, and I want you guys to write what you think the pathophysiologic chronology is. All right. And then so we'll talk about it. So I just want to point out, so this is, I still remember when I was a medical student, like we had a question like this on the test. I was like, no one knew the answer. No one knew. And even afterwards, no one really understood why. And glancing through this is not, you all got to the fact that he took barbiturates, but yeah, I don't think any of you got the reason why. So I am going to show you, because this is actually surprisingly a pretty common question that you're going to see on either step 1 or step 2 or shelf exams. So I'm going to walk through exactly why And we're going to start with the summary. So the summary again is, if I was in a quick sort of testing environment and I was timed, this is how I would think about it. So it takes barbiturates, so prolonged mobility, inability to withdraw from pain. That's going to be the critical thing. He's going to be in pain because he's going to have ischemia because of the external pressure, but he's not going to move. That's why it was so important that he wasn't withdrawing from pain on the GCS. So muscle breakdown, so rhabdomyolysis leads to kidney damage. So I know you'll find this is actually a pretty common question on both step 1 and step 2. So we'll talk about it, Andy. Yeah. So let's discuss this. So Alexa, all right. So, blood flows in large part because there's a pressure gradient, right? So the aorta has the highest pressure, the arteries are going to be next, the arterioles are after that, and then the capillaries, right? Makes sense. Gradient. So Alexa, this is an impossible question that I wouldn't have known at your stage. However, do you happen to know what the typical pressure in the capillaries is? Yeah, I had to look it up. So it's about 20 to 30. If you remember 20 to 30, that's pretty good. Technically, it's 16 to 30, but again, it's going to depend on which capillaries you're talking about. Alexa, we'll go with you next because again, that was an unfair question. So what's the basis of capillary refill? What are we actually doing?
So I don't know, but I think maybe testing the perfusion in the distal extremities.
Sure. But Andy, can you tell us a little bit more? So we're testing distal extremity perfusion, but what's the basis of it? What does that mean, capillary refill? How do you do it?
I don't know if my answer is going to be any better, but for example, I think if you pinch your index finger or whatnot, and then how fast the refill of the blood comes back. So it checks your cardiac output and how much blood is perfused there at the extremity. So I don't know if that's any better, but yeah, that's all I know.
Right. So the way that the capillary refill works, right, is that oftentimes you'll push down like a nail bed. So you push down, you'll put pressure on, it'll blanch. And it blanches. Yeah. So it blanches, right, because there's no blood in it. By the external pressure, you're squeezing out the blood from basically the capillaries or the small vessels. When you release it, the blood's going to flow back in. So the speed with which it flows back is an indicator of relative tissue perfusion and roughly of cardiac output. So they'll use it a lot in pediatrics. So if a kid's really dehydrated and they have a really low preload, very low intravascular volume, like blood volume, if you do a capillary refill, if you evacuate in their finger the blood, because they have such a low cardiac output because their preload is, then it will take a lot longer for their capillaries to refill. Does that make sense? So that's the basis of capillary refill, right? So it's basically looking it's a rough measure of cardiac output, basically. Cardiac output / perfusion. So boogie. So pressure ischemia, right? You may not have even heard that word before, but what would you guess that means?
So when you have constant pressure on a particular area, you're physically occluding the vasculature of that region, so you can't get perfusion through the area. I think we see that all in pressure sores of patients in convalescent facilities that aren't being turned over appropriately. Also, I guess in compartment syndrome. Right?
Yeah, that's right. Yeah, so basically some sort of external pressure. Immobility is probably the major one, but even endotracheal tubes. So those of you that are interested in anesthesia or critical care or all internal medicine, this is pretty important. So some sort of external pressure causes the blood flow to decrease the tissue. And again, ischemia just means that there's more demand than supply. So if I restrict the supply of blood, eventually you can get ischemia. And if it's prolonged, if it's really bad, it's either a really high pressure or a really long time, you think it's worth it.
That's why when we intubate our patients, we only put 10 cc's of air at the cup, correct?
Yeah, 10 cc's is a lot. Again, it totally depends. That's why you're supposed to measure it. They don't do this so much in adults. I shouldn't say this, but in kids, you do this a lot. So you're trying to, you measure, you'll get what's called a manometer and you'll basically connect it to there's a little long tube that connects it to the cuff. I'll see if I can point it out later when I show you the picture of the endotracheal tube. But yeah, you basically connect it and you can measure the pressure in the cuff. That's the idea. So Shama, what pressure would be needed to cause ischemia / tissue necrosis?
So this is an external pressure, essentially. Oh yeah, it says it right there. I mean, a pressure that is greater than the blood pressure in the blood vessels.
Yeah. Essentially, yeah. There's not one correct number, right? So it's this sort of a trick question. So like I was mentioning before, it depends on a couple things. One, how much demand does the tissue, if it's something like muscles where they have their own store of glucose. It's not as bad as, say, like the heart muscle, which has no reserve. It'll depend on the patient themselves, right? Like how much blood supply, how much oxygen supply is carried by the blood. If they're anemic, it'll be less. It'll take less time to cause necrosis than if they had normal amount of RBCs. If they had heart failure, decrease in blood supply. But generally speaking, the higher the pressure and or the longer the duration, the risk of ischemia or necrosis is higher. Right? Like it's just common sense, right? The longer it takes or the higher the pressure, the risk of ischemia and necrosis is higher. It's interesting is that there's nothing, I tried really hard. There's not like one number though. That's what I was hoping for. It would have been so nice to be like, oh, actually capillary pressure is usually about 20. So like anything above 20, like that's probably true, but again, it's going to depend on the duration. You can't just use one number, unfortunately, but yeah, you can use this concept to explain a ton of different clinical scenarios, including the one that we saw that none of us knew. So this is the general idea, right? So you've got arteries and blood's flowing through the arteries, and then you've got capillaries and the blood's going to flow from the capillaries through the veins. So the idea with pressure ischemia is that there's some sort of external pressure, right? So something is going to push from the, be it the patient's weight, if they're unconscious and they're just laying there, either because they took barbiturates and they're unconscious, or because they're under anesthesia and they're unconscious, or whatever. There's some sort of external pressure. That external pressure is going to compress the blood vessels and thus decrease the amount of blood in my capillaries, thus decrease the blood supply to my tissues. So again, the more pressure there is, the longer the time there is, the greater the risk of having cell death from this. Pretty simple concept, but something that literally was, I never learned this in either medical school or residency. And I would suspect that very few people have learned this concept before in a formal way. So prolonged/high pressure is ischemia. Pretty simple. So let's talk about some clinical relationships between these things. So Danielle, what's the underlying pathophysiology of a pressure ulcer?
Yeah, so it's just what we talked about is that the weight of the person's body or extremity is basically constricting blood flow to a certain area, or I guess the pressure of the weight or extremity and not moving causes the ulcer to form. I guess like maybe it breaks down the skin layers.
Exactly. Breaks it down. Why?
Because the pressure is constricting any blood flow. So maybe they become ischemic and like necrotic.
Yeah, exactly. Necrosis means basically cell death, not because of apoptosis. So when you die from ischemia, it's necrosis. Whereas when you die because some lymphocyte told you to die because of like mess or fast jam, like that's apoptosis. It's like a conscious decision that the cell or some cell made, right, to either kill something or for me to kill myself as the cell. Necrosis means I'm not making a choice. It's just I'm dying because I just don't have enough energy. So yeah, exactly. So prolonged immobility, prolonged external pressure on the tissues, tissue ischemia, necrosis, and then yeah, breakdown of that skin. Makes total sense. So Deb, how about rhabdo from immobility? What's the mechanism? What do you think?
I'm not sure, but
Think about it, right? It's the same general mechanism as a pressure ulcer. So just apply it to muscles.
So because of mobility, blood stasis or there's decreased perfusion to the muscle, and so the muscle undergoes necrosis. So there's potassium release and CPK release. So it's also from tissues.
Boom. Yeah, exactly. Same mechanism. It's just that, right? Instead of it being like, because your muscles have, right, skin or CPK, and all cells have high amounts of potassium on the inside. Why? Because the sodium potassium ATPase, right? So yeah, makes total sense. So same as above, prolonged immobility, prolonged external pressure on tissues, tissue ischemia, muscle necrosis. That's it. And then you release all the stuff from those dead muscles, right? How about Hadra? This is something that was near and dear to me, right? What's pressure, or sometimes called postoperative alopecia? What does that mean? How does it happen?
Yeah, so during the operation, the patient has their head in one direction. The pressure-dependent areas of the head are under pressure throughout the operation. And if you don't change the position of their head, there will be ischemia and the blood flowing to the follicles will be decreased. And so there will be necrosis resulting in alopecia.
Boom. Yeah, exactly. Yeah. What kind of cases do you see this in, do you think, Hadra? What's the common characteristic of these surgeries, do you think?
Any surgery brain surgery, where you have to keep your
brain surgery is definitely on their head, so no, not
It's neurosurgery.
No, it's just
Not
any
sure.
long surgery. Because again, normal tissue has like reserves, right? Metabolic reserves. Like it might have glycogen or might be able to decrease its like metabolic demands or whatever. So this is something, so yeah, prolonged immobility, usually surgery, right? You'll have hair loss in the area of the high pressure. Because again, like Audrey was saying, you'd have just ischemia because of the pressure. This is one of those things that they warned us about. I remember when I was I don't know if this is true everywhere, but it was true at MGH. On call, there's 4 people overnight and 4 residents and 2 attendings overnight. And so sometimes what'll happen, so MGH does a lot of specialized surgeries, and one of the ones that they do is like hand repairs. So if someone like puts their hand in like a blender, or I remember one guy, I remember, oh man, I was on call I was the head resident on call on July 4th. There were 2 people that blew off their hands from fireworks. One of them was still drunk when they got there. It was awful. And they're really long cases because sometimes they've got to repair the nerves and like the blood vessels, and they get out that gigantic basically like microscope, and so they're doing very fine work. But anyways, they take a really long time sometimes. There have been some hand cases that take a day or almost a day. And so you have to be really careful in those cases because the patient's just sitting there and they're under anesthesia and they're not going to move because of the pain of ischemia, because you were anesthetizing, you were literally suppressing, right? The whole point is that you don't want them to move when they're getting cut and all this stuff into them. So what you're supposed to do is you're supposed to like lift up their extremities from time to time, right? Like their head, you're supposed to massage their head, find like the pressure points in like their legs and like massage their legs, turn them. Because again, they're not going to move themselves. As you're sitting here, as you're listening to this, you are shifting unconsciously in your seat. You don't even have to think about it. It's just like a reflex. But you do not have those reflexes when you're under general anesthesia or when you're like really intoxicated from a drug or alcohol. And so these are the scenarios in which you see this. But yeah, so I can think of me next time, right? Next time you think of pressure ischemia, think of Alec as a resident just sitting there and massaging some unconscious person's head, hoping that they don't develop like a bald spot. The other thing you're supposed to do is, you've probably seen this, is that they have it's like I don't know if I have a picture, but it's like a gel donut. It's basically like a donut, and it's made of like soft gel. Because the idea is that you want to distribute the weight of their head over a wide area. Because if you were to just lay, it's like a pillow basically, right? A pillow it will distribute the weight of your head over a larger area. Boogie's saying that he's sitting on one of those right now. Yeah. So that's the idea, right? These pillows are basically to try to distribute your weight evenly so that it's more comfortable, so that you have less ischemia, basically. But the same thing exists for your head. And so you're supposed to always have that, especially for long surgeries. And they're super expensive. It's one of those things that they would always be like, where's the gel pillow? Like they get mad if you lost it. He says Amazon. So Luis, why doesn't everyone's muscle break down? Why don't because this person, they had rhabdo, but they didn't get pressure ulcers. So if you get rhabdo, but not pressure, like from pressure ischemia, why wouldn't you also get pressure ulcers? Like, why is that? This is a hard one. Basically, for whatever reason, muscle and subcutaneous tissues are more susceptible to pressure-induced injury. So what they say is that if you have a pressure ulcer, it's actually pretty bad. It's actually really bad. They say that it's like the tip of the iceberg. And again, I don't really know why.
I don't get the question. Is the question why does everyone that has rhabdo also doesn't have pressure ischemia or like pressure?
No, why don't they also get pressure ulcers in their skin? So like that guy, our guy, had rhabdo, but he didn't have, if you looked, he wouldn't have necessarily had a pressure ulcer. Is that your muscles and your subcutaneous tissue are more susceptible? Again, I don't know why, but they just are. It's the reason why I bring this up is because if someone has a pressure ulcer, right, if it's bad enough that it's caused your skin to necrose, it means it's pretty bad. And there's also probably a lot of other problems that you've had as well. Poogie says, because of the direction of the force on the specific, maybe.
Because if they're getting rhabdo, for example, they could be having rhabdo from a clot. They could also be having rhabdo from other types of ischemia that are like intrinsic to some sort of flow that's happening to any of the deep vessels. Whereas if you're getting a pressure ulcer, right, for example, like where you were saying, if the skilled nursing facility, grandpa is on there for 3 days and hasn't moved, you have direct pressure directly onto the skin itself, which is now you're getting ischemia all the way from the surface of the skin deep down all the way to the bone, correct?
True, but that doesn't explain why you would have muscle and not, this is from pressure-induced injuries.
Oh, sorry, I misunderstood then.
So sure. Like you could get rhabdo from, a clot too. One of the thoughts of how it could happen would be like if you developed a clot, say from static or like turbulent blood flow because of compressed blood vessels. I guess that's also possible, but just from pressure injury. So even from pressure injury, you're more likely to get a muscle necrosis, rhabdo, versus something like a skin necrosis. So Danielle's asking, if you had prolonged rhabdo, would you eventually get ulcers? Yeah. So if you had prolonged pressure, I think maybe the better way of asking that is, the more precise way is to say, if you had prolonged pressure ischemia, would you eventually get a skin ulcer? And the answer is yes. Yeah, eventually you would, But the first thing that you'll get is myonecrosis and not necessarily skin ulcers, which I found interesting. I actually would have thought it was the reverse, but all right. So right? Let's think about this. We sleep, at least I hope you guys sleep, right? If you want to maximize your learning capacity for 7-8 hours a night, maybe some of you even more. Why don't we get pressure ulcers or like, why don't I, because if like I had a case like ours and if someone didn't massage my head, like I might get pressure ischemia from that, especially if I didn't have that gel pillow. But why doesn't that happen to us?
It could be Tempur-Pedic mattress. You move around in your sleep a lot, fidgeting, rolling over.
Exactly. Yeah. Because we respond to the pain and discomfort. So we'll move. So there's no areas that are ischemic for too long. Or if you're Shama, your solution is that you don't sleep. But yeah, like
I've actually got rhabdo from not sleeping. So this is a great topic. And it was
not sleeping?
Yeah. So you guys know, Alec, like for my disease, I don't sleep a couple nights and then I crash and am asleep for too long. So the immobility caused me to have rhabdo and like sleep for about like 20 hours, I think. And then I went to work out and then I had rhabdo. So this is all pretty interesting.
Wow. So deeply asleep and for so long. That is crazy. I have never heard of that.
Yeah, that's what the doctor said too.
Oh, because I've heard of, so the other classic situation for rhabdo on like an exam is like someone runs a marathon, right? So same thing, ischemia is just demand more than supply. So in that case, your demand is just really high, but your cardiac output just can't meet just because you're running for so freaking long that like you just can't meet the demand of the muscles. And so the muscles, but I've never heard of that. Wow. Wow. So you were so like literally unconscious for just so long and just so deeply that you didn't shift, and at least you didn't shift enough that you couldn't prevent the ischemia to the muscles.
Basically.
Thank you for sharing. I'm sorry that.
Yeah, thanks for listening, guys.
Were you like really sore? What were your symptoms?
Oh my God, I was in so much pain. I knew I had rhabdo, basically. My muscles were all sore, but I couldn't even move it. And I told my fiance, I think I have rhabdo, which she has no idea what that is. And then my friends who are physicians are like, no, you don't. That's crazy. But it's like a different type of pain. You like feel it in your muscle. Yeah.
And then I would like CPK and your creatinine.
Oh yeah.
Was your
my
CPK? Did you have like?
Yeah, it was 22,000.
Your CPK was 22,000. What was your creatinine?
Yeah, my creatinine was fortunately my kidney function was normal. Like it was chill. Yeah, for everyone, like the upper limit of CPK is I think 500, and mine was like 22,000. And then I just realized like, I'm not able to pee. So then I freaked out because that's complication. I went straight to the ER and said, give me IV fluids. And that's when we found out it was 22,000. Sorry to hijack a little lecture, but yeah.
Crazy. Wow. Thank you for sharing. That is,
Good luck, guys.
Heard that before, but that makes sense in a scary kind of way.
Yeah.
Wow. Man, so you guys are never going to for your pressure ischemia now. And you definitely need to sleep, right? Definitely need to sleep. All right, so Sujith. So in USMLE rhabdomyolysis questions, right? It's a very interesting scenario, but what normally precedes rhabdo, right? Now that I've pointed this out, you guys are going to see it everywhere because it's just about every time.
Anything like it could be like medication induced, like statins or marathon.
Sure. I guess that was a bad question on my part. You're right. So yeah, so it's anything that increases demand. So Pooja says like seizures is where she's seen it on STEP. Sure, that's true. Again, the mechanism there is demand increase, right? Your demand increases in your muscles, and so it exceeds the supply, and so you get ischemia, causes muscle damage. In the case of, sure, I mean, like you can get, yeah. But how about like, why else? So Boogie, you said crush injuries. So what would be an example of a crush injury?
And usually it was, I think I saw a couple questions or like prolonged extrication. Like, for example, the patient was like pinned right in a car accident and we couldn't cut him. I actually had a patient like this. We couldn't free him out because he was so mangled up underneath his dashboard. Like, I was afraid if we didn't free his leg, we would have had to cut off. I had to call one of the orthopedics guys to come in and actually sever the leg just to get him out of there. But I guess in the questions that I've seen, there's a couple of them were just like entrapment type of injuries that led to the compartment syndrome.
Yeah, but even that's external pressure. It's not.
Oh, yeah.
Even that's external pressure. So I guess this was not a good question. What I think the answer I was fishing for was oftentimes, right? And not examples that you guys said, but oftentimes, and you guys probably weren't aware of this, but oftentimes the rhabdo questions are an intoxicated patient. So let that sink in for a second, right? Oftentimes it's an intoxicated patient. So the reason is because these patients will have suppressed brainstem reflexes, so they won't move in response to pain. Right? So your reflexes are that you will respond to pain, right? Even unconscious, you'll respond to pain. And so very often it will be someone that's drunk, someone that overdosed on opioids, someone that overdosed on barbiturates, but someone that took too much of some sort of like illicit substance, not even illicit, some sort of CNS depressing substance. And now that I pointed this out, you're going to see it hopefully. Because what's interesting is that even though when I see rhabdo questions, this is by far the most common scenario that I see rhabdo, you guys probably didn't register to you guys. You probably saw a large number of rhabdo questions, but you just didn't realize it because you didn't understand the mechanism. Pooja says mind blown. What do you mean, Pooja?
Nothing. I just never thought it like that. Like you're saying, like we probably don't even recognize it, and we're scavenging for things that, like, what meds cause the intoxication or what substances cause the intoxication, and therefore whatever labs and stuff that the question gives. I never thought about it in terms of like pressure-induced rhabdo in an intoxicated person. That's just a whole another realm just opened.
Yeah, totally. No, and it's funny because I didn't know this either. Like it took me, I can't remember. Like I remember. So the embarrassing thing is that this came up when I was like a first or second year at Stanford, like in medical school. There was a question. They had these, I don't know, questions where you would discuss like the clinical case and it ended up being rhabdo and no one knew it was rhabdo. But even afterwards, like no one could explain why. Like I don't even think my attending could really explain like what was going on. They just like, it just happens. I don't know. It's just one of those mysteries. And I tutored a Stanford student at one point not too long ago, and he said the same thing. He was like, yeah, there was that one case for the patient rhabdo. I still don't know why. And so eventually I just was like, I need to figure this out. But yeah, it's pretty simple. And now that I know it, it's interesting because I'd say the majority of USMLE questions that I see now that deal with rhabdo are because of that. Or at least I should say the majority of questions that are brought to me about rhabdo have to do with this scenario.
Is something that you like figured out? How did this come about?
I'll show you how, because the issue, it's something I've thought about a lot, right? Like the issue of pressure ischemia is very real, right? Boogie was saying earlier, right? Compartment syndrome is really just a form of pressure ischemia. And 20 is roughly the cutoff. Again, I spent a lot of time working out this stuff, but there's a lot of disagreement about what you use as the cutoff even. Because I used to think, compartment syndrome is 20 millimeters of mercury, like just done. It's like a pressure, but that's not true. There's like different like criteria that different people use. So that's unlikely to be a test question. Again, because if people can't agree, if experts can't agree, then they're not going to. But yeah, the idea of external pressure causing ischemia, again, as we'll talk about, it happens in the case of prolonged intubations. It happens in the case of prolonged being unconscious from anesthesia and getting a bald spot afterwards, from being intoxicated and getting rhabdo. All of these things, they all have the exact same mechanism. And if you understand that, it becomes a lot easier. Even Shama being so sleep deprived that he was asleep so deeply and for so long that he had rhabdo, same exact mechanism. So it's pretty crazy. Yeah. So Andy's asking, how does the statin and fibrates cause rhabdo? That's a big question. I think it has to do with, for statins at least, I think it depletes coenzyme Q, which I don't know, for whatever reason causes rhabdo. I actually don't know why, but I think the mechanism has to do with coenzyme Q. It just decreases abduction. But again, I don't know why that would cause rhabdo. Question. If someone knows, please let us know. But yeah, so again, intoxicated patient, that's it. So look out for it. So when you do these questions, again, you want to think through the pathophysiologic chronology. And again, for this one, you definitely want to use the card associated with this vignette. So Yuki, for an anesthetized patient, why is it so important that you do positioning and bed padding, right? they're like the most comfortable beds you're going to find in the hospital are like those anesthesia beds. Like, why? Like, why are the beds so comfortable? Why are they so padded? There's just pillows everywhere in the OR, everywhere.
So ultimately, it's the presumed excess padding is going to be largely in the emphasis of trying to decrease the amount of pressure that's distributed into one particular location and try to make it so that it's more evenly distributed to reduce the incidence of pressure ulcers from even happening.
Yeah, and pressure ulcers. Because remember, the things that you really are worried about are like the really sensitive structures. So like nerves. Nerve palsies are really common after surgery. Someone's in like lithotomy for a while and you didn't pad their lateral lower extremity. And so they get like a common perineal injury because it's pressing up against the fibula. Like that's pretty common. I think that might actually be the most common. It's either the first or the second most common like nerve complication, but nerve palsies are really common in anesthesia overall. So yeah, so basically you're trying to prevent the patient. So in anesthesia, you are actually actively trying to prevent the patient from moving in response to pain, right? That is by definition, if you think about MAC, right, minimum alveolar concentration, that by definition, that's how you define one MAC. Right, is 50% of the population won't move to surgical stimulus. Right, so in other words, if I cut you, are you going to move? Right, the whole point is that you don't want them to move, and so in anesthesia, that's what it's trying to do. And so it's so important to do positioning and bed padding because again, they're not going to move in response to the surgical stimulation, but also in response to the pain of having ischemia. And so yeah, you need to prevent that sort of like nerve or tissue damage. So pretty important. That was like one of the things I was so worried about when I did anesthesia. I was like, gosh, I don't want to wake up with some palsy or something, right? Like they can't move their legs. I don't know, that always terrified me. So pressure and ischemia. So Alexa. So if you were to get tracheal stenosis or tracheomalacia, right? Tracheomalacia meaning like softening of the trachea, or tracheal stenosis meaning like narrowing of the trachea. After intubation, what's the mechanism and who's going to be at greatest risk?
Wow, this is hard to mention. I'm not totally sure.
That's honestly, I think you've gotten some of the harder questions, especially since you haven't done clinical practice yet. So it's usually in those that have prolonged intubations. So classically, these are the people that get it, right? So someone that was intubated for a really long, usually 2 weeks or more. So the cutoff, the number that you should remember is 2 weeks. So the idea is that the endotracheal cuff, which I'll explain in a second what that is with pictures, but the balloon presses on the mucosa, and the mucosal pressure is again about 20 millimeters of mercury. And so the tracheal tissue will necrose, and so you can get either stenosis, right? If you get more fibrosis than you get weakening, then you can get stenosis, or you can get tracheomalacia if the cartilage itself just gets weak and flabby. Does that make sense?
Is it the balloon is pressing on the blood vessels that supply the mucosa?
The balloon presses on the mucosa. And so within the mucosa are blood vessels. It's not like it's only compressing the blood vessels. It's compressing everything. But one of the things it compresses is the capillaries to the mucosa. Kind of crazy when you think about it. So let's talk about endotracheal tubes. So Boogie says, one proposed mechanism suggests that decreased cholesterol concentration secondary to statin therapy may result in alterations in myocyte membrane cholesterol. A second proposed mechanism, so I didn't know that, but interesting. That's interesting because statins decrease cholesterol. That's a little hand movie. Second proposed mechanism involves depletion of isoprenoids that control myofiber apoptosis. And a third mechanism, depletion of ubiquinone coenzyme Q, may account for the potential myotoxicity of statins. Yeah, but like why? So I've heard the coenzyme Q one, but like why does coenzyme Q? I don't know. That doesn't make sense to me. Andy, who may or may not be interested in anesthesia. So what's an endotracheal tube? Tube that you put into someone. So endo, again, use the words, right? If there's anything that I could teach you guys, all the words make sense, unless it's like someone's like Ducow's triad, right? Unless it's something like that, where it's an eponym. Like the name usually makes sense. Endotracheal tube. So what would you guess, Andy? An endo, what does endo mean?
Like within, yeah. So it's a tube inside the trachea.
Right? Great. Yeah. So it's a tube, right, that you put in the trachea. And the whole point is that you're trying to ventilate them usually. And yeah, so this is how you do it, right? So intubation, when you do an intubation, if you've ever probably heard of intubations, right? That's what I always joke. That's all anesthesiologists do is they just put tubes in people. They intubate people, right? That's what this is. So you have a blade and you put the tube and you're trying to put it in the trachea. Your goal is to get it in the right hole and not the wrong hole. You want to put it in the trachea, not in the esophagus. Otherwise, it's embarrassing, but it happens to all of us, including me. But yeah, so this is the tube. And Boogie was mentioning that you want to put 10 cc's of air in it. 10 cc's is a lot. Like so what you do is you inflate it. So this little tube is connected. It's hard to see, but it runs all the way to this balloon. And so you insert air through here and it blows up this balloon here. And this balloon is what keeps it basically secured. It's one of the things that keeps it secured, and it prevents like mucus and phlegm, and if you vomit it or anything, it prevents it from actually entering into your trachea because it's sitting there in your trachea. So you inflate it, but yeah, you don't want to inflate it too much. Question so far? So that kind of makes sense. So this is what's going to cause the pressure ischemia, right? And yeah, so I answered this question. So what part of the endotracheal tube is most likely to cause tracheal stenosis? It's the balloon, right? So it's this balloon right here. So let's talk about this. So the endotracheal tubes might sit in your trachea for a long time. So this is an X-ray of an endotracheal tube. So usually when you're almost always in the ICU, right, you'll look at the placement of the endotracheal. So this is your lungs, this is your heart right here, and this is your endotracheal tube. You see this sort of white line right here. So there's a radiopaque line in it. So it'll help you visualize it. So you can see the tip of the endotracheal tube is somewhere like right here. And when I was at your guys' stage, I wouldn't be able to see this, but this looks like the carina right here. So this looks like where it's splitting. And so you can see how it's sitting there. And so sometimes that balloon is going to sit there for a very long time. So if this patient, let's say, is unconscious, this is a real patient, right? If this patient's sitting there and they're unconscious, right? So they say induced medical coma. Really what that just means is they're getting like a propofol infusion or something to keep that essentially anesthetized for a long period of time. But if that happens, again, they need to be intubated, right, to prevent all of their secretions and stuff from falling down into their lungs and to allow them to breathe. If that happens, then you can get ischemia because that balloon is going to be pressing on the walls of your trachea. So question so far, because I'll be honest, I didn't know any of this stuff as a medical student, and I only know some of this stuff because I went through anesthesia residency and actually saw tracheal stenosis. So question so far. No one. All right. So let's talk about compartment syndrome because that's basically another example. Boogie. So what is compartment syndrome and what's the mechanism of pain?
My understanding, I'm sure it's pretty complex, but my very basic understanding was that you had physical damage to the underlying structure of the muscle tissue, with below the fascia or deep within the fascia. And because you're having tissue damage, you're going to get, cytokines, you're going to inflammation. And as that occurs, because of the structural rigidity, right, of some of that connecting fascia that actually separates the specific muscle groups from each other, the region can't quite expand. And so it ends up compressing on itself again, causing more ischemia. And now you have this weird cycle of increased pressure, more ischemia, which is now causing more inflammation, increasing more pressure, now increase more ischemia. And is that kind of what it is now?
Yeah, I think your explanation is going to be actually better than mine. Basically, the idea is that in an enclosed space, in the case that Boogie was saying, it's enclosed, and what Boogie was saying is actually more common, or is very common, is that you have fascia, right? So fascia is this really fibrous, but also very tough and non-distensible tissue that surrounds your muscles. And so it's basically like a very thin but very tough cast that surrounds your muscles. So if you have enough swelling in your muscle for whatever reason, or in your tissue for whatever reason, right? Either because there's some sort of, I don't know, I guess it could be an infection, or it could be because you had some sort of damage and now there's inflammation or whatever. But if the tissue is swelling and it can't, but it's with an enclosed space, right? Then the pressure is going to increase. And if the pressure increases too much, you're going to get ischemia. Yeah, cool. Makes sense. So the classic P's, those shama, what are the classic P's that are associated with compartment syndrome? You guys have probably seen this, but
I can't believe I forgot this card. I know
pain. What else?
Pulselessness is a later complication.
Very good. Yeah. And because again, but you can make sense of it, right? You don't have to, you can guess these. You can guess it from the mechanism. So pulselessness is going to happen because of why?
Because they're, like we were saying, the pressure's ischemia, essentially. There's no way for that
to be for you to lose your pulse.
A lot.
Higher than what?
Yeah, your blood pressure.
Yeah, higher than your arterial pressure, right? That's like super high. So that's going to be really late.
Yeah. And then same concept goes towards like paresthesias. I think that's also
potentially
because they're more sensitive to.
And why would you get pain or paresthesias?
Wait, paresthesias is like numbness, no?
No, that is paresthesia means that you have it's an abnormal sensation where there's either a sensation or not a sensation present. Yeah, so pain, paresthesia, paralysis, pulselessness, and pallor. And so why do they occur, Danielle? We explained some of them, but yeah, why would that make sense?
Yeah, I think for the pain, is it that you're compressing like pain fibers? And I guess same with the paresthesias, like you're compressing like the nerves within that compartment of where the increased pressure is occurring. So essentially pressing them so much to the point where they cannot function.
Yeah, either that you're compressing the nerve itself or you're compressing the blood flow supplied in the nerve. You're accomplishing the same thing. If you compress the nerve, you can also compress the surrounding blood supply.
Yeah. So then would that lead to the paralysis? Yep. And then the pulselessness would, like Sharma said, with the basically your pressure within the compartment is much greater than the actual arterial pressure. So then you have no pulse because you have no blood flow. And then that goes along with pallor, because if you have blood flow, your extremities going to become pale because it's going to be ischemic.
Yeah, exactly. Boom. Yeah. So tissue ischemia can give you pain. Also nerve ischemia could give you pain. Decreased arterial flow, right, can give you pallor, pulselessness. Nerve ischemia and compression will give you the paresthesia or paralysis. Perfect. So Yuki says poikilothermia. I don't even know what that means. Yuki, can you explain the poikilothermia for compartment syndrome?
Poikilothermia specifically, I believe it means is inability to regulate temperature is, I believe, like the official definition of it. But generally it's going to be, I think that it's going to be colder than usual, just because of the fact that there's going to be obviously there's the pulselessness, but before the pulselessness, you do have a pulse, but then the first thing that gets really occluded is going to be venous return. And so then obviously you have a bunch of sitting blood that's not actually going back to your heart. And so that is going to become cold.
Now, I would imagine too, it's ischemic, right? The metabolic activity is going to be lower because heat is a byproduct, unless you're actively like shivering, even in the rain. It's a byproduct of biochemical reactions. So yeah, that's why like brown fat, when you have like uncoupling, you're just cycling through the electron transport chain just continuously, and you're doing all those chemical reactions again and again. I guess exothermic reactions. So I don't want to get too interesting. That would make sense. Poikilothermia. Boogie says, I think reptiles are also poikilothermic. Really? Man, I didn't even know this was a thing. What is now someone's got to explain what does poikilo mean? Because I don't know. Oh, it means cold. Oh, cold-blooded. Interesting. That's cool. I didn't know that. I knew the reptiles were cold-blooded. I didn't know that we called it poikilothermic. Wow, that's cool. Learned something new. All right, so we are back at our vignette. So now what I want you guys to do is I'm going to read it again, and then we're going to go back to the Google Doc, and you're going to write your pathophysiological chronology. So I read at the speed that I would read it on an actual test to show you how slow I read things on test, because you want to read it slowly. Otherwise you're going to, otherwise I just don't understand what's going on. If I read quickly, I can't think. So a 29-year-old man is brought to the ED 30 minutes after being found unresponsive on the floor next to an open bottle of barbiturates. Examination shows diffuse movement to painful stimuli. He is intubated and mechanically ventilated. Creatinine is 4.7 milligrams per deciliter. What is the pathophysiological chronology? All right, so I'm going to have you guys take a little bit of time to write your pathophysiological chronology, and then we will come back and talk about it. All right, so I'm going to start to give feedback to some of you guys. So Danielle, I am really impressed. That one's really good. So previous healthy guy consumes barbiturates, increases GABA activity, which increases the chloride channel duration, increase negative concentration inside the cell, hyperpolarized cell membrane, so decreases the action potential. Yeah, makes it harder to do action potentials, so decreased physical movement. Again, I guess this is the part, again, it's not just that it's decreased physical movement, really, it's the fact that you are suppressing his nervous system, right? So you're suppressing all of his reflexes, including the reflex to move in response to pain. That's why it's so important that we didn't really talk about GCS, but if you think about the GCS, right? So G is promoter, right? GCS, 4 is movement in response to pain, like withdrawal from pain, is 4. 5 points on the motor scale is that you can localize pain, and 6 is that you can follow commands. So diffuse movement to pain, I think, is GCS of 3. So in other words, he doesn't respond. He's not necessarily withdrawing from pain. He's just moving in response to pain. There's a difference. And so that also means that he's so unconscious that he's also unlikely to necessarily move from just like the pain of the ischemia of laying in one position for a long time. Boogie says GCS of 8, or I think it's 8, but yeah, they say intubate. And do you know why that is, Boogie? Why you're supposed to intubate for GCS of 8?
My understanding was that because at that point we could assume that the patient most likely does not have the capacity to protect their own airway.
Yeah, exactly. Yeah, it's for airway protection. Yeah. So what does it mean, airway protection?
So the gag reflex is eliminated. We assume that the higher functions are gone to the point where the gag reflexes are eliminated and they won't be able to have the unconscious stimulation to be able to try to protect the airway to actually close off the glottic opening, correct?
Yeah, exactly. Yeah. Not only close off the glottic opening, but also cough. So if I vomit, I'm fully conscious and it like starts to go down into my trachea, my glottis is gonna close, like meaning my vocal cords are gonna close, like my trachea is gonna get irritated, so I'm gonna cough like crazy. A little bit might get in, a little bit, but like the majority is not gonna go in. But if I'm drunk, out of my mind and unconscious, right, and I vomit, then yeah, my brainstem reflexes are not going to necessarily be there. And so if I don't have the brainstem reflexes, then when stuff starts to go down into my trachea, I'm not going to cough. My glottis is not going to close. When it gets down all the way to my alveoli, it's still, nothing's going to happen. So that's why it's so important. It's because I was always like, yeah, why is vomiting such a big deal? Like when someone's drunk, like it's a big deal. It's a really big deal because yeah, they will aspirate. There was a guy I treated when I was an intern who passed away, unfortunately. He was a young guy. He was found with like a syringe and a needle next to him and he was unconscious. And I just remember we couldn't get his, like he had aspirated, very clearly had aspirated because, or I assume he had aspirated because we could not get his oxygen to him. He's a young and healthy guy, right? There's no reason that with 100% FiO2, like you should be able to get his oxygen to improve, but we could not get his oxygenation to improve. And so we did a CT scan later for some reason because his neurologic function didn't recover like we expected. And so we eventually did a CT scan and like his brain just had tons of holes in it. But it was because he had aspirated and because he had taken drugs, he didn't cough it up. He didn't like close his glottis, like nothing. It just went straight down into his alveoli and prevented the diffusion of oxygen into his blood.
So Alex, was he basically having just a severe form of ARDS at that point in the ICU because of aspiration?
I guess so. Yeah. Essentially, yeah. Yeah. That would have been, the definition. Yeah. Based on the Berlin criteria, he would have met the criteria. Yeah. Because his P to F ratio was super, super low. So, all right. So yeah, Danielle, that was really good. So boogie, drug overdose, GABA, hyperpolarization, loss of consciousness, medically induced coma. Oh, interesting. Oh, that's fair. I guess I didn't think about that. Maybe, yeah, you're saying maybe it was our fault. Maybe it was iatrogenic. I don't know. It's possible. It's also reasonably possible that it was from the barbiturates themselves and that caused him not to move before. Because you would think, hopefully, right, like a normal ICU is, if they're a medically induced coma, they know to help the patient and stuff. But yeah, we'll go to deep muscles. Yeah, ionic is good. CK, myoglobin goes to the kidneys, cause decrease in GFR, serum creatinine is going to go up. Good. Very good. Very good. Great. All right. So I will tell you what I would have put, but I think I like your guys' better. So again, my summary we discussed before. The more detailed one would be barbiturates, suppresses the nervous system function. Again, that's the critical part, is that you're suppressing nervous system function. So possibly comatose, right? Like low GCS. So like his motor would be like maybe 3. Hypoventilation. So because of that, because he couldn't protect his airway, presumably, and I presume he was also hyperventilating, he intubated him for airway protection, and he had immobility, right, without withdrawal from pain. So either from the fact that he was intubated or from the fact that he was like immobile for so long before, the external pressure increased, compresses the capillary beds, leads to muscle ischemia and breakdown of muscle, rhabdo. So there's myoglobin and potassium and other stuff within the muscle. And so when you necrose, all that's going to leak out. And so the myoglobin can damage the kidneys, GFR would decrease, which would increase your creatinine. Perfect. Awesome. Questions, concerns?
Alec, I have a question. Is the damage to the kidney from the myoglobin and there's not from the CK?
I don't know. I think it's myoglobin. Yeah, I'm pretty sure it's myoglobin. But I guess maybe the CK could be. I think it's myoglobin then.
Yeah, I actually had a UWorld question on this, and I was wondering the exact same thing. And UWorld specifically said that the myoglobin degradation, it formed a toxic metabolite that is what is responsible for causing the acute kidney injury. So I think it's the degradation of the myoglobin.
I know that the myoglobin gets stuck in the renal tubules. For rhabdo, that's why you get like acute kidney injury, is because the myoglobin gets literally like it clogs the tubules. So that's why you need aggressive IV hydration so that the water can maintain like continuous blood flow towards the tubules and outbeat the myoglobin.
Yeah, because if what I'm just saying is correct, which I have every reason to believe that it's true, she says that the myoglobin precipitates within the tubule. Mutation happens because this concentration of something is too high. And so it's when you grew crystals on rock, maybe you guys did rocks when you were a kid. I grew crystals on rocks when I was a kid. That's how you do it. You supersaturate some solution and then you give some sort of nidus, like a rock, and then the crystals just form. So so the way to counteract that is you just need more solvent, right? You need more water. So yeah, that's one of the reasons why you're supposed to just flood the kidneys with water. So it was good that Shama got IV hydration for his rhabdo.
Sorry, guys.
Going up to the question, same scenario on this, but same setup, but it was a suicide attempt, and he was found face down, immobile. But UWorld was going on and explaining it from the perspective of the body shunted blood to the ischemic area, and that's what he had, elevated creatinine. They were trying to explain it from the perspective of pre-renal, what's the term, azotemia.
Shunted it to the ischemic area. Interesting. I have a hard time believing that. To an extent, that's true, because it's not like there's no blood flow to the area. There's just not enough. And yeah, I guess that would make sense. So that you would have like local metabolites like lactate or adenosine or things that cause local vasodilation. That kind of makes sense. I believe that. It certainly plays a role. All right, guys, I look forward to the next session. Thank you very much. So I know that we've gone over this now 2 times, but I want to do it, or 1 time. But I want to do it again just because it's really important for what we're going to talk about. So I'll probably include this in the Google Doc so that you guys can see it. But I'm just going to have this here so you see again, LFTs, not tests of liver synthetic function, even though they're called liver function tests. So bilirubin, as a reminder, is a breakdown product of heme. Direct is conjugated, indirect is unconjugated, right? It explains a lot of the things like the color of poop and pee, also the color of bruises and other things. AST and ALT are basically, they're enzymes found within hepatocytes that are only released mainly released if you have hepatocyte damage or death. So that's the main reason why AST and ALT are elevated. Alk-Phos is the main reason is actually because of an increase in synthesis, right? So this will become really important because we're going to talk about all of the LFTs and the patterns today. And because you'd think that if it was just because of leakage from damaged cells, that AST, ALT, and Alk-Phos would all be up in the equal amounts, but they're not. And it's because they're elevations for different reasons. AST and ALT are mainly because of damage. Alk-Phos is mainly seen in biliary stasis because of an increase in synthesis. Right? Obviously, AST, ALT, and Alk-Phos are found in other things that are not just hepatocytes. Alk-Phos is the one that you really should know about, although AST is also found in like muscle and stuff like that. But Alk-Phos is found in bone, liver, and placenta, among other things. And as a reminder, for acute liver failure, the most common ways of measuring synthetic function, there's a couple others other than PT and albumin, but the most common ones are PT and albumin. So acute liver failure, PT's up, albumin's normal, and then chronic liver failure, PT's up and albumin's low. That has to do with half-lives. So with that in mind, I want to go to our question. So a 25-year-old male has a 1-week history of fatigue and nausea with a 2-day history of skin yellowing. His past medical history is unremarkable. He denies any alcohol, tobacco, or illicit drug use. He works in a local restaurant. His temperature is 37.8, heart rate is 90, blood pressure is 115/78. Physical exam is significant for jaundice. His liver is slightly enlarged without tenderness. Abdominal exam demonstrates no spider angioma or fluid wave. What is the pathophysiologic chronology? So his labs, you can see, are bilirubin total is 6.2, direct bilirubin is 2.8, Alk-Phos is 200, AST is 1221, alanine aminotransfer, so ALT is 1349. PT and albumin are normal, and he's got positive anti-hepatitis A virus IgM, negative HIV IgG, and he's got anti-HBs antibody, which is positive, and then anti-hepatitis B core antibody, which is negative, and negative hepatitis B surface antigen. So I want you to walk through the pathophysiologic chronology. So let's go through the pathophysiologic chronology. So the summary would just be that he's got, from fecal-oral transmission, he's got an acute hepatitis A infection that leads to, we'll talk about the different patterns, but a very clear hepatocellular LFT pattern, sometimes called intrahepatic. So that's why because it's an acute infection, that's why it's IgM and not IgG. He's got inflammation of the liver, which we'll learn anytime you have inflammation of the liver or basically the gut tube or any of the derivatives, so liver, gallbladder, appendix, or pancreas, you can get nausea, just possibility of nausea. And so we'll talk about the detail later, but that's the big picture sort of summary of what's going on. So our summary of key concepts. So The main thing that we're going to go through today is to talk about the different patterns that you see for LFT abnormalities, because this comes up a lot. And so there is a more intuitive way of thinking about it, which is to think about it very similarly to how you think about like kidney failure. So you can think of it just like there's pre-renal, intrarenal, and post-renal. There's also, you can think about it for jaundice especially, you can think about it in terms of pre-hepatic, intrahepatic, and post-hepatic. It doesn't work quite as well as it does with the kidneys, but it works like 90% of the time, which is pretty useful. It's a pretty intuitive way of thinking about it. I am going to include, however, the more common way of describing LFT abnormalities, which you'll see more in textbooks. And certainly that was what we learned at Stanford and what they did at MGH, which is thinking about it in terms of just recognizing the pattern. So isolated hyperbilirubinemia, which is kind of like the pre-hepatic, hepatocellular, which is essentially like the intrahepatic, and then cholestasis or cholestatic, which is basically your post-hepatic. So there's a lot of overlap between them, which is why I included them in one. Sometimes you'll also see infiltrative, which I didn't include, but that's basically where you see just an increase in alphos and none of the others. So the other thing I want to talk about is a way of thinking, a systematic way of thinking about nausea and vomiting that is, I think, really helpful. Because when I was at your stage, it was really hard for me to think about nausea and vomiting. Because I was like, I don't know, like, can esophagitis give you nausea? What does that tell us? What does it mean? So the punchline is going to be that anytime you have obstruction or anytime you have inflammation of a gut tube or one of the four buds, so the pancreas, liver, appendix, or gallbladder, it can, not always, it can lead to nausea and or vomiting. Obvious caveats are that not all causes of nausea and vomiting are GI related. Right? You can obviously get GI. There are lots of causes of nausea and vomiting, which we're not going to talk about today. We're just going to focus on the GI causes. But it's useful to know what are the things that can cause nausea and vomiting from the GI. It's also important to note that the lack of nausea and vomiting does not rule out GI causes. Right? So if you don't have nausea, it doesn't mean you can rule out like hepatitis. That said, it is still a really useful way of thinking about nausea and vomiting. It's also really useful because you can use this as an analogy to think about coughing. Because again, I always had a really hard time of thinking like, what would cause coughing? What's a good systematic way of thinking about coughing? And so in the same way that obstruction or ultimately pressure or inflammation of the gut tube or its derivatives can cause nausea and vomiting, basically the same thing in the respiratory tract can cause coughing, right? If you increase pressure on the wall of the respiratory tract, so a bronchoscope, something where you're looking into someone's lungs and you brush the side of the wall, they will cough like crazy. I can tell you that. Personal experience. And inflammation, also the same thing, right? Like, why do viral illnesses cause so much coughing? Asthma. Why do steroids help with reducing coughing, right? It's basically the same idea. All right. And with that, we will get started. All right. So our systematic approach. So as a reminder, there are two most common causes of approaches for LFT abnormalities and for jaundice. So again, the most common is to look at just the pattern recognition. So you'll see hepatocellular, isolated hyperbilirubinemia, cholestatic, and then sometimes invasive. It's essentially high alk phos, but everything else is close to normal, including the bilirubin. So it's sometimes included, so I describe it just so that you know, but it's not that common. So bilirubin, the more intuitive way of thinking about it is to look at causes of jaundice. So causes of jaundice, one schema is to say prehepatic, intrahepatic, or posthepatic. So they're essentially interchangeable. And so in the hospital, you'll probably hear this more often, but in your head, oftentimes I think it's actually more useful to think about in terms of pre and post. But I included both so that you can rock both the intuition as well as frowns. So let's go to Paula. So Paula, prehepatic versus intrahepatic versus posthepatic. So using your knowledge of bilirubin, explain which would have the highest direct conjugated bilirubin and which would have the least, if it was pre, intra, or post.
The highest conjugated posthepatic.
Perfect. Yeah, exactly. And why does that make sense?
Because when we're talking about posthepatic, we are saying cholestatic. So then if we have a problem, if the problem is not in the liver, so we're going to be able to conjugate the bilirubin. So from indirect to direct.
Exactly. Yeah. Great. So posthepatic is going to have the most. Sorry, I shouldn't show it to you. So which is going to have the least?
Then it's going to be the prehepatic.
Good.
Yeah.
Yeah. So post, right? Because the liver is fine in posthepatic, right? So you can conjugate just fine. The problem is that the conjugated bilirubin, for whatever reason, cannot make it into your GI tract. So there's cholestasis, right? So that would have the highest conjugated bilirubin. Intrahepatic is going to be in the middle. So you're in the process of conjugating it. So you're conjugating some of it, but because of damage to the liver cells themselves, you're going to have spillage of bilirubin from inside the hepatocytes. The prehepatic, it hasn't even there's the least direct bilirubin. You are increasing the production of unconjugated bilirubin in most of these cases. The other cases of isolated hyperbilirubinemia would be like what we saw before with Gilbert, where the problem is that you just can't conjugate it. This is why it's not quite as perfect of a schema as it is to say pre-renal, intrarenal, post-renal, because it gets a little messy to say like pre-hepatic for things where it's like it's a problem with conjugation. Is that it's a problem with the liver, but it looks like the pre-hepatic. So that's why I think it's probably not quite as common, because it will not cover 100% of the situations. It is more intuitive though, which is why I included it. So pre-hepatic versus intrahepatic versus post-hepatic jaundice. So using your knowledge of bilirubin, explain which would have the darkest urine and which would be the least dark. All right, we'll move to Matan. So Matan, what do you think?
So we look at the solubility or the polarity of the molecules. So direct bilirubin is polar, therefore it's not bound to albumin, it's freely filtered, it'll end up in urine, urine will be dark. Unconjugated or indirect is non-polar, it's bound to albumin, not freely filtered, it won't darken the urine.
Boom. Yeah, exactly. So in other words, the post-hepatic is going to have the darkest urine. Absolutely. And it's for exactly the reasons that you said, because the direct bilirubin will be soluble in the water, and so it can actually enter the urine. And so that's why post-hepatic is going to have the darkest urine. Intrahepatic, again, is going to have the middle. It's sort of like Goldilocks. It's going to have the middle amount of conjugated bilirubin, so it's going to have maybe a little bit of dark urine, but not too much. And then the prehepatic is going to be mainly unconjugated bilirubin. So less than 20% of it's going to be conjugated. And so that is going to be largely not dark urine. It is almost never dark. Great, or at least from the bilirubin itself. All right, so Joni, so using your knowledge of AST and ALT, which would have the highest levels?
So AST and ALT are indicative of intrahepatic. Would it be?
Yeah, great. Yeah, so the highest in intrahepatic. Great. And why?
It's AST and ALT are indicators of hepatocellular damage.
Yeah, they're enzymes that are found within hepatocytes. If you have damage to the hepatocytes, they'll be high. Great. And so great. Exactly. So post-hepatic might have a mild elevation, right? Oftentimes a little bit, which is why I think people get confused, because there will still be some elevation even in post-hepatic, presumably because you still get some damage from cholestasis if you get backup of bile, although it's not nearly as much as it is in intrahepatic. So prehepatic has virtually no elevation. So the reason why it's called isolated hyperbilirubinemia is because that's basically all you see. All you see is the increase in bilirubin that is indirect. All right, Grace. So using your knowledge of ALK-Phos, which would have the highest levels?
So would it be post-hepatic?
Yeah.
See, I know that increased ALP is associated with cholestasis. I'm trying to remember.
Yeah, it's not super important to remember why. There is an increase in synthesis, right?
Right.
So the reason is because of an increase in synthesis. The reason why I include that, as opposed to just memorizing it, is because it helps explain why because it is actually an enzyme that is found within hepatocytes. So you would think that if you damage hepatocytes directly, that ALK-Phos should increase the same amount as AST and ALT. But the reason why it's not is because the major reason why ALK-Phos goes up is because of an increase in making of ALK-Phos. And that happens for whatever reasons that are unclear to me, when you have cholestasis. So it's interesting. It's not, at least in the papers that I read, we don't know what ALK-Phos does in what the major purpose is in the GI tract. So there is a small elevation, right? So it's the opposite of the AST and ALT, right? So for hepatocellular, you have a lot of AST and ALT and a little bit of ALK-Phos. For the post-hepatic or cholestasis, you'll have a lot of ALK-Phos and a little bit of AST. A lot of ALK-Phos, a little bit of AST, ALT. So prehepatic, again, it's isolated hyperbilirubinemia. You don't really see much of any of the ALK-Phos. So sometimes you will see something called R factor. So let me tell you what R factor is. I don't think that it's one of those things that you should memorize. I think the concept is more valuable. So I want to talk about this. It was actually in the white book for MGH for like the interns that talk about like LFT abnormality. So it is used sometimes, but I think the concept is probably more valuable because I think people still get really confused about like how to recognize these patterns. So R factor in the equation is ALT over ULN, which is the upper limit of normal. Sometimes you'll see ULN. So ALT over the upper limit of normal divided by ALK-Phos over the upper limit of normal of ALK-Phos. So the major downside to this, because you may be wondering, because you'll see ULN sometimes, like for example, in like Light's criteria or the Light criteria, you'll see upper limit of normal for looking at total protein, or no, albumin. I think it's albumin. And so like you might wonder why is this not a fixed number? It's because the upper limit of normal varies by the hospital. So I looked up what the upper limit of normal was for the USMLEs. So for alk-phos, it's 70, and for ALT, it's 20. So if you do the math, right, if you flip this around, right, so the upper limit of normal, right, so you're dividing by something you're dividing by. So if you flip this, right, the upper limit of normal with alk-phos and do the math, right? So the upper limit of normal with alk-phos ends up on top, and the upper limit of normal of ALT ends up on the bottom. And so if you look at the ratio of these, it ends up being 3.5 for the USMLEs. Again, for your particular hospital, it will be different, but for the USMLEs, I did the math and it's 3.5. So what would be then, if you followed this, and then I don't think I did a very good job of explaining this, so probably couldn't follow this, but we'll see. Sujith, what would be a quick and dirty way to calculate the R factor? Right? So ALT over the upper limit of normal divided by alk-phos over the upper limit of normal. So what would be a quick and dirty way to calculate it? And what does it tell you?
ALT by ALP.
So it would be, so R factor is ALT divided by ALP times 3.5. So in other words, all of this times 3.5, right? So this is written with the correct order of operations, but I just want to make this really clear. So in other words, if R is above 5, that tells you that it's hepatocellular. If R is less than 2, that tells you that it's cholestatic. And so again, this quick and dirty way really is only like USMLE specific. It will vary depending on the hospital. I have some examples of this. So I want to show you how you can use this and why it's valuable. The reason why I am even bringing up R factor in the first place is because just to say, because you'll see tables like this where it's, oh, what's most prominent? So AST is most prominent in the intrahepatic. Alk-phos is most prominent in posthepatic. If that's with you, you don't really have to worry about R factor. It's more when they're both elevated and you're like, gosh, I don't know. What's more elevated than normal? Geez, I don't know which is most prominent. That's where R factor comes in. And also to tell you what's mixed, because if it's between 2 and 5, that tells you that it's a mixed pattern. So Sujith, let's say that the ALT was 900 and the alk-phos was about 300. What kind of LFT pattern would this be and why? Those were the only two things you knew. Could you calculate the R factor and tell me what the LFT pattern would be?
It will be, are you asking if it's hepatocellular or pre-hepatic? This is hepatocellular.
Great. And how did you come to that?
It's more than 3.5. So 3 into 3.5 is around 10.
Great. Yeah, perfect. Exactly. So you can do it one of two ways, right? You could do it like Sujith did, where you like eyeball the R factor and see is it 5 or less than 2. That was the point of this question. But if you are comfortable just saying, well, ALT is like really high, alk-phos is just like a little high, that's also okay. Honestly, that's how normally I go about this. It's just that that's a lot harder to communicate to someone else. It's a lot harder to teach someone. Say, oh yeah, just like eyeball it and say, like, oh yeah, alk-phos is a lot higher than normal, or ALT is a lot higher than normal, and alk-phos is just a little bit higher than normal. That I think is harder to do, especially if you don't have a lot of experience looking at LFTs. So if you're not comfortable with that way, then R factor is for you. So you can think about it as the elevation of the ALT is much more prominent, but to be more precise, you can do what Sujith did, which is to say ALT over alk-phos is about 3, right? And so 3 times 3.5. So this is USMLE specific, 3.5. So 10, so that's a lot more than 5. So this would be hepatocellular. Cool. All right. So we are going to practice this more. Do you want to take a shot? Oopsies. Want to take a shot at this? So what pattern of LFT abnormalities is this? And what condition is most likely?
Would we first look at, I guess, the ALT? So that is going to be 1349. And then I guess that would be high. And so with the ALP at 200, so let me do that real quick. And then multiply that by 3.5, right? So 23, which is greater than 5. And so that would signal me towards an intrahepatic.
Perfect. Yeah,
Okay.
exactly. Yeah.
Cool.
So I think that's the easiest. So again, so the other way of doing it would be to say what?
The other way would just be like looking at ALT is much, much higher than ALP.
Yeah, or just to say, yeah, exactly. Or just elevated over normal is much higher than the amount that alk-phos is elevated over normal.
What was the normal value again for the two?
I think 70 is alk-phos. Upper limit is so alk-phos. The thing to remember is alk-phos is a bit higher than ALT. So I think it's 70
Okay.
for alk-phos and then 20 for the USMLEs for.
Okay, yeah. That's a part that I wasn't familiar with. But yeah, that calculation is actually like much more straightforward for me. So that's cool.
Good. Again, I include both just to give you guys like a sense. I should be completely upfront with you. I don't use R factor. I just eyeball it and say, man, this is a lot higher than this is like real high. This is a little high.
Right. Having that frame of reference for sure. But having the equation to calculate it out for me like that, it was a lot easier.
And I figured, it was good. In fairness,
Cool.
The other thing is that you can also use the percentage of the bilirubin, right? So the direct bilirubin is a little less than 50%. So that's also very characteristic of an intrahepatic or hepatocellular pattern.
For sure.
Cool. So I included all of these so that you can be really clear. And again, let's be honest. It's patients, the real world, even the tests, they're not going to have necessarily read these textbooks. Like sometimes maybe the direct bilirubin is going to be more than 50%, a little bit more than 50%, or that's like the major one. Sometimes like this doesn't fit quite as perfectly as you want it to, but go with the thing where most of it's going to make sense.
Right. I think honestly, like when doing like practice questions and using this approach, it'll help the application part of it be a lot easier.
I think so. And so again, this is why the IgM is positive, but there's no IgG because it's a acute infection. All right, so Saba, how about this? So walk us through. So again, I want you to use as many of the different, because we want to practice this. For these purposes, I want you to use as many of the different ways of determining what LFT patterns it is. Yeah, so go for it. I've only given you one, I guess. Saba, are you there? You have to remember to unmute yourself.
Oh, sorry. Yes. So in this case, because the indirect bilirubin, which I calculated from total bilirubin minus direct bilirubin, that would be 5. Because the unconjugated bilirubin is higher, that would make me think that it's a prehepatic. Because, if you haven't made it to the liver to get conjugated yet, then, you wouldn't expect.
Now look at the other labs, because again, I give you a ton of clues here that they weren't AST, ALT, alk-phos, but I give you a ton of clues. So why is there an isolated hyperbilirubinemia in this case? I'm looking specifically at the hemoglobin and the direct Coombs test. You may not have been here last week.
No, I wasn't, unfortunately.
Okay, that's okay. So I'll pick on someone else. Zach, you're taking your test real soon, so let me hear it.
All right, so direct Coombs test. So you have second autoimmune reaction. You have antibodies against RBCs. They break down the RBCs. They break down the RBCs. And in intravascular, like hemolytic anemias, your indirect bilirubin is going to be high, and your hemoglobin is obviously going to be low. So you're shredding RBCs.
So interestingly, intrahepatic, actually extrahepatic is more associated with high bilirubin.
Did I say intrahepatic? I meant to intravascular. My bad.
And that's because, and let's be clear. So the reason is because if you have intravascular hemolysis, if you have shearing from DIC or HUS or something like that.
Oh, okay, yeah.
You don't have, the hemoglobin is free floating.
Yeah,
it hasn't had time, the macrophages haven't had time to just consume it, turn it into bilirubin.
Yeah. So should I rephrase this as like when you have an autoimmune hemolytic anemia, then your indirect bilirubin is going to be high?
Yes. Yeah, exactly. Yeah. Perfect. Because what question are you answering? What is that?
So like why
what question exactly are you answering with the direct Coombs test?
So you're answering, do you have antibodies against the RBCs? Is that what you mean?
Yeah.
Or antibodies against
the question is, did immune-mediated hemolysis happen already?
Okay. Yeah.
Versus the indirect is basically saying, could you have
potentially have it if you added RBCs?
Like, do you have antibodies that could cause?
Yeah, this is like what we did last week.
Yeah, exactly. Perfect. Yeah, exactly. So that's why. So in other words, so you've got autoimmune hemolytic anemia, right? And so the pattern is, prehepatic, right? So isolated hyperbilirubinemia. So and the way that you can tell is that there's the D-bili is low, and I didn't include the LFTs, but the other ones would have been normal. And so again, the direct Coombs is telling you the RBCs are already coated with antibodies. In other words, the question that you're asking is, did hemolysis already happen?
Yeah.
Perfect. All right. So let's go to Mary next. So Mary, what pattern of LFT abnormalities is this? And what condition is most likely? All right, we'll go to Deb. Deb, what do you think?
So there's elevated alkaline phosphatase. And so the ratio of ALT to alkaline phosphatase is less than 2. And so this is a post hepatic pattern.
Great. What else can you use to help? Okay, so that's good, right? So you said alkaline is really high, ALT is not that high. And if you were to do the R factor, then it's less than 2, so great. So that would be posthepatic. What else can you look at to argue that this is posthepatic?
The direct bilirubin is high.
Yeah, exactly. It's mainly direct bilirubin. Great. And if you want to quantify it, it's 80%, much more than 50%. Great. What condition is this? Now we got to put it together, right? So there's 2 parts to lab analysis, right? Like you got to say, what's the pattern, right? But you also have to look at the bigger picture and say, what exactly is going on?
There's leukocytosis, and then the CBD is dilated. Is there any cholelithiasis or?
Yes, there is. Where is the stone? Where is the stone located? And why is the leukocyte high?
The CBD is dilated, so the obstruction site, is it cystic duct or CBD?
Yeah, it's got to be the CBD, because if it's in the cystic duct, your common bile duct should not be dilated. Why is the leukocyte count high? Why is the white count high? It's pretty high. 22,000 is high.
There's a leukemoid reaction due to infection or inflammation.
It's very good. Exactly. Yeah. So this, I was trying to show cholangitis. Yeah. That would be the easiest way to look at, to explain all of these things. You've got really high alk phos, mild elevation of the AST/ALT, and really high D-billy relative to the total bilirubin. Your white count is really high and you've got a dilated common bile duct. This would be very concerning for ascending cholangitis. So your direct bilirubin would be, so we talked about this. So the pathophysiology, just to be very clear, so you've got gallstone from the gallbladder that lodges in the common bile duct. So the common bile duct pressure is going to increase for whatever reason, probably because of pressure ischemia. You'll have bacterial translocation, right? Because there's bacteria that's just present in the lumen. So they can infect the wall. And as they infect the wall, that infection can ascend. So that's how you get cholangitis. That's the basic idea of getting cholangitis. So the bacteria, it's really easy then to enter the bloodstream. And so that's why you can get such a profound leukocytosis. So this would be pretty scary, pretty severe, or potentially pretty severe. Questions so far? So we just covered the LFT patterns and did some practice, as well as giving you various different ways of thinking of differentiating between the different kind of patterns. Questions so far before we talk about nausea, vomiting, and then make an analogy?
Alec,
Yeah.
it's Metan here. On the slide before, so what is that actually heading towards renal spanted, where you get the hypertension and the altered mental status because you're basically almost in septic shock?
Yes. Oh yeah, exactly. I think that is why. Yeah.
Cool.
I think that's why you get, because it's basically, it's basically septic shock. Yeah. You hyperperfuse your brain. And so you can get.
It's nice. I never knew why. I always knew that it happens, but it's nice to connect the dots.
Yeah.
Cool. Thanks. Yeah.
I have a question, Alec. Would your PT be elevated in that last scenario if it was like really bad and the white count's not like insanely high? It's not like 70,000, but could your PT be,
I guess though, probably not though. No, probably not. Could it happen? Sure. Absolutely. Yeah. But I don't, because you'd have to say that there's a liver failure. Is there liver failure? I mean, it could, in theory, sure. Any infection, any form of septic shock could, in theory, give you liver failure. So if you showed me a picture where like the PT was elevated, could I see a conceivable mechanism how they could have had liver failure? Absolutely. But could you rule out ascending cholangitis because their liver synthetic function is normal? No. Does that make sense?
Yeah. Thank you.
Yeah. Great question. Fantastic question. All right. Other questions?
Sorry about that. It's a question about septic shock one. The reason why we said septic shock, is it because of increased leukocyte count?
Oh, sorry. You caught me. Technically, septic shock is, so the definition of septic shock is actually that you've given enough fluids and they still don't respond to fluids and you need pressors.
Right.
So we don't actually know that they have septic shock here. So I guess technically what I think Matan and I should have said is to say that shock, in other words, insufficient perfusion of your end organs, which in this case, the organ we care about is your brain, right? If you're trying to describe why someone with sepsis could have like encephalopathy or altered mental status, shock could explain why you have altered mental status. But technically, based on these labs, you do not know if this is septic shock, right? Technically, you'd have to say like severe sepsis.
Correct. Yeah.
I like it. Yeah. Gotta keep me honest. Precision
Sorry,
with
I'm sorry.
language. Thank you. No, that was really good. Matan? Yeah, absolutely.
Alec, what's the reason that bilirubin or hyperbilirubinemia causes pruritus?
Oh, interesting. So it's not that bilirubin, my understanding is it's not the bilirubin itself that causes, it's a correlation, right? It's BUN increased. People that have high BUN can get like uremia. It's not because the BUN itself, it just correlates with it. I think the same thing is true with bilirubin. My understanding, the way that it was explained to me is that it's because of the bile salts, right? So bile salts emulsify fat, right? So they help basically dissolve and increase the surface area of fat. So that can get into your skin, into your fat. So my understanding is that the pruritus comes from the bile salts itself, not bilirubin. Yeah. All right. So let's talk about some nausea and vomiting, right? The punchline is going to be that nausea and vomiting for the GI tract and cough for the respiratory tract are both confusing, but at least there is an intuitive way of thinking about it. There's a sort of a systematic way of thinking about it. And before we do that, we're going to talk about the gut tube. Zach, what are the derivatives of the gut tube?
Yeah, so derivatives of the gut tube comes from endoderm. So you're going to have your pancreas, liver, appendix, and stomach.
What else?
And then your intestines. So small intestine, large intestine. Yeah.
Perfect. Yeah, basically everything from like your esophagus all the way
Downwards,
down.
yeah.
Like,
sorry, those are the gut buds, right?
exactly. Yeah. The systematic way of thinking about it is like your entire GI tract from your esophagus all the way to the upper part of your anal canal, right? That entire length of bowel esophagus. Plus the 4 buds that attach to the GI tract, the bud off of it, pancreas, liver, gallbladder, appendix. Great. And so Feluke, can obstruction of the gut tube or its buds cause nausea/vomiting, and why?
Yes, it can, since there's going to be pressure.
Yeah, exactly. So there are mechanoreceptors, right, that sense pressure, as you said, in the GI tract wall. This forms the afferent signal to the vomiting center in the brain.
Alec, I have a question.
Please.
Is there a serotonin associated with this? Because I was just doing a UWorld question about how you give on like a serotonin blocker for anything that causes like irritation.
I think it's actually, so like ondansetron, I think is actually a central mechanism.
Oh, okay.
Yeah, the H3, I'm pretty sure is a central mechanism. I'm pretty sure serotonin is not involved in the afferent signaling. I could be wrong. But I'm pretty sure that's a central mechanism. Because again, the reason why I say that is because ondansetron works for things that aren't just GI related. So like postoperative nausea and vomiting, that's like the most common drug is to give Zofran.
Oh, I see.
All right. Good question. But again, this is why it's confusing. So what I'm trying to do with this nausea vomiting portion is to elucidate one aspect of a very confusing topic. Right? Nausea vomiting is very confusing. Like many things can give you nausea and vomiting. I'm not trying to explain everything that can cause nausea and vomiting. I'm trying to explain the things, like a systematic way of thinking about the GI causes of nausea and vomiting. So to hopefully make it more attractable. So Vi, what effect generally does inflammation have on nerve excitability?
Inflammation, doesn't it increase the excitability?
Yeah, it does. Yeah. So I went really deep down to this rabbit hole, but I can tell you, I can summarize basically by saying that inflammation generally causes both the nerves and the nerve receptors to be sensitized. So again, that's a huge field of research. I was shocked at how many papers and things, like stretching back decades. But generally, this is true. So if you are interested, some of the more representative findings would be prostaglandins increase mechanoreceptor sensitivity. Inflammation also causes an increase in sensitization of nociceptors. There was also these really interesting studies where they looked at why inflammation can cause nerves themselves to become sensitized. Like nerves generally don't respond that well to touch. They don't respond that much to like touch. However, in inflammation, they do, and there's like interesting mechanisms for why. But the general way for your stage in general, right? I think the best way to think about this is that inflammation causes nerves and nerve receptors to become more sensitive. Leah, in the GI tract, what effect does inflammation seem to have on nerve excitability? How can you use this to explain the symptoms of things like inflammatory bowel disease, like Crohn's or UC?
Okay, so if we're saying that inflammation increases the nerve excitability in the GI tract, then in something like Crohn's, that's a chronic inflammatory state. So you're like chronically having the vagal afferent nerves in the GI tract like constantly stimulated. And so you're going to get like probably nausea and cramping and that sort of thing.
Yeah, nausea, cramping, diarrhea. So inflammation leads to sensitization to distension, right? There's a number of papers on this. If you want to look at the PubMed IDs. This is what they are. So the thought, I didn't really know this, but the thought for why like IBD happens, or one of the thoughts for like why the symptoms of IBD happen, is that you get chronic inflammation. So that causes you to become more sensitive to distension. So remember, distension is the signal for the gut to move things through, right? So that's why you give like bulking agents. That's why fiber, right, makes you have to go to the bathroom. It's because you can't digest, well, it's insoluble fiber, right? You can't digest insoluble fiber and it's bulky. And so it distends your gut, and your gut senses the distension, and it causes contraction of the GI tract and causes the peristalsis. And so one of the very common symptoms of IBD and inflammation of the gut in general is tenesmus, right? The feeling like you have to poop, but you're not able to, like, you still have to poop, but like nothing's coming out. And then another symptom that's really common is diarrhea. And so a really tantalizing explanation for that is to just say inflammation sensitizing the gut to distension, which that is true. That seems to be pretty well established. So inflammation sensitizes the gut to distension, presumably because of increase in mechanoreceptors or increase in sensitivity. And so that would explain both why it feels like you always have to go, or that you will go but you still can't get everything out, right? Because you're really sensitive to any sort of pressure, and why you get diarrhea. Because again, even just a little bit is going to cause you to feel like there's a lot there, which is going to cause your bowels to move quickly. Kind of cool. Yeah. This is also, as I went down the rabbit hole, hypothesized to play at least a role in things like irritable bowel syndrome. Right? So irritable bowel syndrome. So it is established that 90% of people with IBS have heightened sensitivity to mechanical distension of the bowel. So one of the most tantalizing explanations for why, and at least it explains it in some, it would explain it in some of the cases, is that you get an inflammation or infection or something. So that will sensitize you to distension. And for unclear reasons, some people seem to be more likely to have persistence of that sensitization even when the inflammation is stopped, which is why they have to run to the bathroom so much, right? It's irritable bowel is like the equivalent of urgency for the urinary system, right? Which again, very similar idea. So if you've got inflammation of the bladder, you will have sensitization of the bladder to mechanical distension, right? So normally you have to distend your bladder a fair amount to feel like you need to pee. If you have inflammation of your bladder, even just a little bit of distension is enough to now make you think that you really have to pee and to set off the micturition reflexes. So again, my goal with this lesson was basically to try to give you general principles for thinking about these very common clinical phenomena, and to try to help you to see the connections between them in a way that wasn't just you have to memorize it, which is why you see all these links to articles and PubMed IDs and stuff, because I wanted to make sure that this was reasonably well established. Okay, questions so far?
Alec, can I go back to my point about serotonin? I don't mean to be a know-it-all about this. This is just literally the last question I did before our class started. So I found the UWorld explanation. Can I just read it out and we make sense of it then? Like
Sure.
the line.
Yeah.
Yes, one line. Yeah, so conditions that cause BI irritation, example, infection, chemo, distension, result in increased mucosal serotonin release and activation of 5-HT3 receptors on vagal and spinal afferents. And then these then relate their impulses to the medullary vomiting center, inducing emesis. So is there? Yeah, so like I literally just did this question before class started, which is why it was like preying on my mind. So it seems as if there's like mucosal serotonin released. Yeah.
Sure.
And then, yeah, so that's, yeah. And
Yeah.
that's like, so the distension causes mucosal serotonin release, which hits 5-HT3 receptors. I think, yeah. I can copy the explanation.
Yeah, let me see. I don't want to, I don't know. The short,
I don't want to disrupt your flow or anything.
the
Yeah.
honest answer is I don't know. It would be cool. I would love for that to be true, but I think I'd have to look into it more.
Yeah, you can look over it later.
Yeah. That's cool. No, I love the connection. So Ghana. So tenesmus. So again, tenesmus is the feeling of incomplete emptying when you're trying to poop. To use the proposed mechanism to explain why, like how the patient feels.
We're talking about how, like, when you have inflammation and it causes increased stimulation, it can cause tenesmus.
Yeah, exactly. Why would that make sense?
I guess that because if like the bowels or whatnot moving too much, that you can't properly empty what's the word I'm looking for? You can't like properly get rid of all the poop.
So I don't know that it's so much. So maybe there is some effect of like you can't get rid of all the poop. Oftentimes, though, I think that you don't have to invoke that. Remember that with inflammation, you get sensitization of the nerves, especially to rectal distension. So even if, right, so normally you have to have a fair amount of stool in your rectum to feel like it's distended. If you had inflammation, do you think you would need more distension or less distension to feel the same degree of fullness?
Oh, you need
Less distension. Yeah, exactly. So if you had enough inflammation, even if you didn't really have much there, it might feel like there was a lot there. Does that make sense?
Yeah, that makes sense.
So that would explain, because I had always memorized that inflammation causes tenesmus. You typically see that in something like UC or Crohn's, but you don't have to, right? And then I looked a little bit further and I was like, oh, actually, you typically see it in inflammatory bowel conditions. I was like, oh, so I memorize that. But really, you don't have to memorize that. It actually makes total sense. Cool.
Yeah.
All right, so Moe, so can inflammation of the gut tube or its buzz cause nausea/vomiting? And why would that make sense? All right, we'll go to Paula. Paula, what do you think?
We're going to use the same theory that we have been using. Since we have inflammation, then we're going to have sensitization of the nerve, and this is going to cause for the person to feel bloated and to feel distension, and then this is going to cause nausea.
Yeah, exactly. Yeah, because you're sensitizing all the nerves. So now a little bit of pressure is going to go a long way. Even though it's a little bit of pressure, your gut's going to think it's a ton of pressure. And so now it's going to think, oh gosh, there's some obstruction. We need to get this out. And you're going to feel nauseous. Completely logic.
Thank you.
Yeah, that's cool. Nice. So Matan, so what is a good way to think about the GI causes? So let's sum it up. So the GI causes of nausea, vomiting. It's a good sort of general way.
So causes of inflammation.
Yeah.
Sorry.
Inflammation or what else?
Obstruction.
Yeah, obstruction. Yeah. Basically anything in the gut tube or its four buds that causes obstruction, so increasing pressure, inflammation, in other words, increased sensitivity to, or a toxin, right? You got to throw that in there. It's the GI tract. But yeah, basically obstruction, inflammation, or a toxin, which is cool. I remember the reason I came upon this was because I was looking at my chart. I was just kept vomiting. She was 4 or 5 at the time. And I was like a typical doctor parent. I was like, let's figure this out. What's going on? Do I need to take her to the urgent care? So I was looking, I was like, oh wow, this is actually a really good way to think, really great way, some random paper. It's a really good way to think about nausea, vomiting, right? And that was basically what they said, obstruction or inflammation. I had the toxin thing. All right, Joni. So can appendicitis cause nausea and or vomiting?
Yeah, it's the same mechanism. Right?
Yeah, same mechanism, right? Hepatitis. Yeah, Grace, what do you think? Grace, can hepatitis cause nausea and or vomiting?
Yes, also the same mechanism.
Yeah, same mechanism. Again, this is what I'm building towards because it was always really confusing to me. Can hepatitis give us nausea, vomiting? Can esophagitis give us nausea, vomiting? Can pancreatitis give us nausea? I don't know, right? Now it's pretty clear. You can, and you've got a mechanism for why. So, Sujith, if you do not have nausea, can you say this is definitely not? No, unfortunately. It'd be so nice, right? That'd be so nice. If you could if there was something that was that sensitive, it was that sensitive, but no. The absence of evidence does not mean the evidence of absence. So unfortunately, no. Sue, so is all nausea, vomiting caused by GI tract mechanoreceptors? Can you tie every cause to this mechanism? No, unfortunately. That'd be nice. That'd be super nice, but no, you can't. Yeah. However, I still think it's important to think about because again, a lot of the causes, particularly the causes that you're going to see on your test, and honestly in real life too, are going to be GI related. And when someone comes in with nausea, vomiting, the first thing that everyone's going to think about is GI, whether it's true or not, it's GI. So it's a good way to schematize it in your head to know how to approach it. All right, so now we're going to tie this to coughing. So Saba, I'm going to make you an analogy, Saba. So nausea and vomiting is to the GI tract like coughing is to the respiratory tract. Right? So Saba, what's a good way generally to think about coughing and the respiratory causes?
I guess with the same concept of increased sensitization.
Yeah. So if inflammation or increase in pressure causes an increase in nausea and vomiting in the GI tract, what would cause an increase in coughing in the respiratory tract?
I'm sorry, my connection was in and out. Could you please repeat that really quickly? Sorry.
Yeah, absolutely. So we're saying that inflammation or pressure cause an increase in nausea in the GI tract. Would it be fair to say that an increase in inflammation or pressure in the respiratory tract could cause an increase in coughing?
Yes.
Yeah, for basically the same mechanisms. If nausea and vomiting is caused by obstruction or inflammation of the gut tube or its buds, then coughing is basically caused by pressure or inflammation in the respiratory tract, trachea, airways, or alveoli. So let's think about it. This comes up a lot. So Deb, what are the 3 most common causes of chronic cough in a non-smoker? So smoking obviously causes you to cough. You got, I guess, inflammation, maybe a little bit of pressure too, but definitely inflammation. So Deb, what are the 3 most common causes? Do you happen to know?
Postnasal drip.
It's pretty good, actually. GERD is the 3rd. So postnasal drip, asthma, and GERD. Great. This is one of those things that you should know because they're going to, especially for step 2, they're going to give you someone that comes in with a chronic cough that's not a smoker, and then they're going to describe to you basically, do they have GERD symptoms or not? Do they have asthma symptoms or not? Do they have postnasal drip symptoms? It's also a pretty common presentation in primary care clinics. So Zach, so bronchoscopy, right? So this is a bronchoscope, right? You stick a little fiber optic thing into their airways and you're trying to look at the different airways and get stuff from the lungs. So if you touch the side of the trachea or the bronchi with a bronchoscope, if I am snaking this in and go boom, and I bash the side of or just lightly touch the side of the trachea, what's the patient going to do and why?
Start coughing and gagging because you put pressure.
Exactly.
And so kind of mimics obstruction.
Yeah, again, it's not really, so it's obstruction in the GI tract. It's not really like,
you said pressure and space.
You have a much lower threshold for, because normally there's supposed to be stuff in the GI tract. So it makes sense that you need a lot of pressure to get to the point.
So it's kind of relative,
Yeah, there's not supposed to be anything in your respiratory tract.
Yeah.
Even just a little bit. Yeah. So they cough like crazy. I can tell you this. Yeah. Having done anesthesia, it's, really, really, unless you deeply anesthetize someone, you just brush the side of the airway. They cough like crazy. So GERD, can this cause coughing and why?
Yes, it can cause coughing because you have pressure, you have irritation and inflammation.
Perfect. Yeah. So it's causing inflammation of the airways. Great. So you can sensitize the mechanoreceptors so you will cough more. Great. All right. So so asthma, can this cause coughing and why?
Yes, because you have inflammation of the small airways.
Perfect. Yeah, exactly. Yeah. What's interesting is that there was I think it was like a NEGEN paper not too long ago where they looked at like the difference between like inflammatory and non-inflammatory asthma and to see who responded better to steroids. And answer, but inflammatory asthma responds much better to steroids, as you can imagine, presumably for this exact reason, or at least partially this reason. So you get inflammation of the airways, so you presumably you're sensitizing the mechanoreceptors, and so you'll increase your coughing. Great. Leah, so postnasal drip, can this cause coughing and why?
Yeah, a similar reason. You have the postnasal drips going down your throat and it's irritating. And so you're, again, similar sensitization going on and then you're going to cough.
Yeah. In this case too, I think you also have the mechanical effect of like you have mucus. There's like stuff there. So presumably that's going to cause coughing too. But yeah, I assume there's some inflammatory component as well. So Agana, what would be the likely etiologic mechanism of a dry cough? Because you see this a lot. And like when I was a medical student, it never made sense to me, like dry cough, wet cough. Why productive cough? Like, why does that matter?
I think it matters because with the productive cough, you have an over secretion of like the glands, which causes like the mucus to stay and you have to cough it up. I feel like a dry cough, there's some kind of irritant, but it doesn't cause like mucus to be built up.
Yeah, exactly. Either because of inflammation or because whatever that is there can't be easily coughed up.
Yeah.
But the more likely thing, usually it's because of just inflammation, right? It's often inflammatory, which again would make sense if you sensitize the mechanoreceptors. That's why even just like a gust of cold air can cause you to have bronchospasm if you're an asthmatic. All right, so I want you guys to update your pathophysiologic chronologies and we will talk about it. So what I'm going to do is, again, so instead of just reading it, I'm going to actually read it and analyze it as if I was going to do it myself. So got a young guy, has a 1-week history of fatigue and nausea with 2 days of yellow skin. So he's got jaundice for 2 days. So a week ago, he started to having fatigue and nausea. So vague symptom, although probably more GI. And now you've got some skin yellowing. So you're thinking already GI, either obstruction or inflammation. His past medical history is unremarkable. So healthy guy, no bad habit. He works in a restaurant. So could be nothing, but exposed to like foodborne pathogens potentially. His temperature is normal, heart rate is normal, blood pressure is normal. So vitals are normal. He's got jaundice. There's something going on with his liver because it's large and it's not tender. And so he's got no signs of basically like cirrhosis. So the labs are really going to be the key then. So already, I don't know, I guess you'd be thinking at this point, maybe something to do with the liver. I guess you'd probably be thinking hepatitis, but you wouldn't necessarily know. Hepatitis would certainly make sense with the restaurant thing because it's fecal oral transmission. So that would make sense. This is where the money is. So he's got about a little less than 50% of his total bili is direct bilirubin, which both are elevated. So that tells you that's something going on in his liver. He's got much higher elevations of his ALT than his alk phos. You could do the R factor, but again, this already is above 5 times the ALT over the alk phos. So already, even without multiplying it by 3.5, you should already, this is very clearly intrahepatic. So he's got no signs of liver failure, either acute or chronic. And this is telling you, so anti-HAV IgM, so this is positive. So this tells you that he's got an acute hepatitis infection. Because again, hepatitis A, we'll talk about this probably next time or one of the future ones, but hepatitis A only gives you acute infections. So if you get IgG, it tells you that you've had hepatitis in the past or you've been vaccinated. So the fact that he's negative means that he was not exposed previously, and this is an acute infection. Because if he had IgG, this would be a protective antibody. The fact that he's got surface antibody, anti-surface antibody tells you that he was exposed to hepatitis B in the past. The fact that he doesn't have an anti-core antibody tells you that he was vaccinated. So he was vaccinated against hepatitis B. And so, because he also has no surface antigen. Had he been exposed to hepatitis in the past, like a live virus, and he was infected, but he cleared it, then both of these would be positive and the surface antigen would be negative. So he's got an acute hepatitis A. So this is my pathophysiologic chronology. I basically just walked you through the first part of this. Again, the nausea vomiting makes sense because you've got inflammation in the liver. So you got sensitization, presumably of the mechanoreceptors. And so Zach, very graciously shared this gem. So he said, the choice of antiemetic therapy depends on the source of the emetogenic stimulus. Conditions that cause GI irritation, so infections, chemotherapy, distension, result in increased mucosal serotonin release and activation of 5-HT3 receptors on vagal and spinal afferent nerves. These then relay their impulses to the medullary vomiting center, inducing emesis. So that's great. That's actually really useful. So this would actually, so it would make sense that the common mechanism here would actually be 5-HT3. So you're sensitizing the mechanoreceptors. And so now the mechanoreceptors are more likely to cause release for less distension, you'll have more release of serotonin. So that is why you will have nausea. The acute infection, as we talked about, is why you have IgM. And then because he's had a prior HPV vaccination, he was exposed. The vaccination, the key thing to remember is that the vaccine is surface antigen, but no core antigen. So because of that, you'll make an anti-surface antibody, but because you're not exposed to the anti-core, you're not exposed to the core antigen, you will not make an anti-core antibody. So this is our summary of key concepts. I won't belabor it. We went over it, but we will include that in the notes. So questions, concerns, thoughts?
This is a random question, but is nausea is it lessened at all in diabetic patients who have like diabetic gastroparesis or anything like that, or is it altered?
I don't think so. That would be interesting. If you told me that there was a case study of someone with diabetes who had knocked out the afferents from their GI tract, and you could blow tons of air into their GI tract and they'd never get nauseous and distend it like crazy. Yeah, I have no reason to disbelieve that, but I don't know that's like a thing.
Thanks. I'm just curious.
Yeah, it's a good question. Other questions? Saba says that was super helpful. Thank you. Oh, great. What was helpful specifically?
Just the way that we described everything, I really appreciate having a systematic approach to think through things because I don't know, tackling things without a clear strategy in mind I don't think that's anyone's first choice approach. But yeah, I just really can't emphasize how much I appreciate giving us a structured approach to these kinds of questions for tests and.
Awesome. Thank you. Yeah, I feel the exact same way. Yeah, I felt like I learned a lot of this stuff in very haphazard ways, and I had to piece together with gum and twine, a general approach. But yeah, it's interesting. It's much more pleasant. It's just much more fun to practice medicine or to do questions or things when you have a systematic sort of way of thinking about it. Cool. Awesome. Thank you guys so much. Again, we are continuing on with GI. I think there may be a point in which we may branch off a little bit and do a little bit of question interpretation, or I've also noticed there's two sort of steps with Anki. So one of the steps, and just learning material in general, the first step that is already a difficult hurdle to clear is if you get a fact, can you make sense of it and make a good card? So if you get this random fact, I don't know, inflammatory bowel conditions, oftentimes you get tenesmus, right? Can you make sense of that? Can you do something where you can make sense of that? That in and of itself is pretty hard. Most people don't do that. They'll just memorize that. And so you're left without a systematic benefit to knowing that fact. I've noticed that a lot of people struggle with that. I've also noticed, though, that a lot of people really struggle with the idea of mastering a broad topic. So I'm probably going to have something in the course, either in the course or lessons or both, where we talk about like where we actually practice this, because I think it's really important. I will say for people whose scores do not improve, I would say the number one reason is they're just not really learning things very well, or they're not really retaining it very well. That's almost always, especially if your scores are stuck at lower amounts, like less than 220, 210 for either step, but especially for step one, it's pretty common to see that being a major problem. So thank you guys very much. I will see you guys next week. So we are going to restart our discussion of renal pathophysiologic chronologies. I hope that this one is better than the last time that we tried this. I want you guys to give me honest feedback though. So we're going to show you the vignette and I'm going to read it slowly like I always do. And I'm going to have you guys write the pathophysiologic chronology. Okay. So a 58-year-old man comes into the physician for a pre-employment checkup. He reports having not seen a physician in 20 years. His temperature is 36.5 Celsius. Heart rate is 70 per minute. Blood pressure is 160/95. And respiratory rate is 15 per minute. His labs are significant for a serum creatinine of 3.5 milligrams per deciliter, blood urea nitrogen of 40 milligrams per deciliter, serum sodium is 140 milliequivalents per liter, and serum potassium of 4.5 milliequivalents per liter. What is the pathophysiologic chronology? Is his serum sodium normal? Why would this make sense? Are his serum creatinine and BUN normal? Why would this make sense? How can you relate the serum creatinine with his blood pressure? So in the session document, I want you guys to write what you think the pathophysiologic chronology is, and we'll talk about it. All right, this actually looks pretty good. And I was watching you guys type down your pathophysiologic chronology, but these are pretty good. I can tell that many of you guys have reviewed renal since the last time we talked. That's great. Perfect. Okay, so what I'm going to do is I'm going to walk you through my summary first of what I would say is happening. And then, again, isn't the only explanation of what this might be. Some of you guys have renal artery stenosis, which is possible. So that would actually be one way of explaining this. But I think the simpler explanation is just to say that hypertension, diabetes, right? So things that those are things that cause chronic kidney failure, right? So the most common thing would just be that he just has kidney failure. So kidney failure means you have a decrease in filtration. Decrease in filtration means you're going to accumulate things that you would otherwise normally filter or eliminate, right? So creatinine, BUN, sodium. That will give you hypertension because retention of sodium is going to cause retention of water. It's going to increase your intravascular volume, causing hypertension and high serum creatinine. Okay, so this is a pretty simple vignette, but the basic ideas behind it show up all the time in renal. And if you don't really understand the connections between them, it becomes a lot harder for you to get those questions right. Not impossible, but it makes it a lot harder. So understanding the individual elements will help you get more questions right. And so that's what I want to go over today. So let's start from the top. Alexa, I saw you were talking about breakdown products, so this is great. But before we talk about creatinine, I want you to tell me, what is creatine? What is creatine used for in the body?
Creatine, isn't that used? I want to say it's like a breakdown product of ATP. But
You're saying one of the words is right. So it is not a breakdown product of ATP. It's actually like ATP. All right, so ATP is adenosine triphosphate. So there's adenosine, the base that we use in DNA. TP is triphosphate. So there's three phosphates, each of which is high energy, which we'll leave it at that for now. Right, so high energy. So it's that high energy phosphate bond that really is like what carries the energy, so to speak, for ATP. But you can also have high energy phosphate bonds in other things, namely creatine. So creatine is basically like ATP, just instead of having three high energy phosphate bonds, it only has one. That's the same idea. Does that make sense?
Yeah.
It's not really breakdown, right? It's a different like molecule, but yeah, same idea. So Boogie, so what adds the phosphate to creatine? What enzyme?
I'm not sure what is adding the phosphate to.
Great. Well, but this is one of those things that you can use your wonderful reasoning sounds for. So what's the name of an enzyme that adds phosphate to something? The kinase. A kinase.
Yes. Kinase. It slipped my first.
Okay. So what enzyme would add a phosphate to creatine?
Adenosine kinase.
Yeah, creatine kinase. Great. So Danielle, so what's the difference between creatine and creatinine? Or how about Deb? Deb, can you tell us the difference between creatine and creatinine?
Creatine is an energy source, whereas creatinine is like a breakdown product of muscles. So they're not like creatinine isn't used for energy.
Kind of. So creatinine is a breakdown product of creatine.
Okay.
Creatine just breaks down into creatinine. Right? Some things just like spontaneously decompose. It's essentially what creatine becomes when it breaks down. It becomes creatinine. You know, if I've got 100 creatine molecules, some fraction of them are going to be turning into creatinine every hour. Let's just orient ourselves to what creatine does and what creatinine does and why we use it. So, right, this is a muscle, right? Very nice looking muscle. This is a blood vessel, right? So creatine, CK, so CK stands for creatine kinase. So kinases phosphorylate things. So creatine becomes creatine phosphate. And then the phosphate is used, so remember in ATP, right? The phosphate is used to cock the myosin head when you're talking about actin and myosin interactions. So ATP, right? Same thing, right? The phosphate in ATP is used, same idea, but because it's a carrier of a high energy phosphate bond. So creatine becomes creatinine, and that creatinine basically goes into the bloodstream and then is carried to the kidneys where it's eliminated. Pretty simple, super simple. So Deb, using the function of creatine kinase, I want you to explain when we would see it elevated in the blood. Why do we use it?
During muscle contraction?
Not muscle contraction, right? Because it's an enzyme. So think about it. It is an enzyme that is inside the muscle. In other words, when would the enzyme, instead of being inside the muscle, be outside of the muscle and measurable in the blood?
So muscle breakdown, muscle
necrosis, muscle breakdown, right? So CK phosphorylates creatine to create high energy phosphate bonds. We already talked about this. So this is found primarily in muscle. So if CK is elevated, it indicates some sort of necrosis or damage in muscles. So Jared, so in rhabdo, right, the breakdown of muscles, what electrolyte abnormalities do you expect to see, and what classic enzyme would be elevated in the blood?
You'd probably see elevated creatine kinase, probably see elevated creatinine because it's the breakdown product.
Not really creatinine. You'll see elevated creatinine for another reason that is just because creatine or myoglobin will damage kidneys and decrease filtration of creatinine. But I don't think it's because the muscle broke down. I think it's because your kidneys failed.
Okay.
But what electrolyte is high? What ion?
Sodium, because it's usually inside the cell and gets pumped.
Is that true?
No. I'm trying to remember which way the sodium potassium pump moves.
Yeah. Well, just think about it. So again, remember, you need strong foundation, you need good question interpretation. So strong foundation means you have good factual knowledge, which is kind of where this is, but I would argue that this isn't an integration gap. So think about normal sodium levels in your blood. What's the normal sodium level in your blood?
Like low 140s.
140. Let's just say 140 and call it a day. Like it's so much easier to remember one number than like a range. So let's just say 140. Okay. What's the normal potassium level in your blood?
4.
4, exactly. Which is higher?
Sodium. So
which is the one that's outside the cells?
So sodium's outside. So potassium will move out when you rupture the cell. So potassium will be high.
Boom. See? So now we've moved from factual knowledge to integrated knowledge. And see how much more useful that is? Both in like a stressful, oh my gosh, like I'm being called on kind of situation, but also I'm in a test and I need to know this to answer the question kind of situation. What are your thoughts?
I feel like it's one of those things where, like, in the test, I'd feel maybe a little less pressure to have just instantly, but at the same time, there's an equal chance that I would just, like, out of a gut feeling, do it and then not think about it as much.
Yeah, totally. You would be one of the few people that wouldn't feel nervous on a test and rush through. So I'd be impressed. I get nervous in those sorts of situations. So it really helps the more I've integrated it. So that was wonderful. Yeah, because again, what's high in your serum, you probably haven't thought about integrating that with the sodium potassium ATPase, but that's exactly why. That's why your sodium is 140 and why your blood potassium is 4. Sodium potassium ATPase, right? Because 98% of all of your total body potassium is inside the cells. So it's like 160. It ends up being 160 millimolar, right? So it's literally 40 times your serum concentration, your extracellular concentration. And what's crazy is that muscle contains 80% of the intracellular potassium. I didn't know that. I didn't know that muscle contains so much of it. So in other words, of all of the potassium, more than about 80% is in your muscles. So I never really thought that would be why your potassium, but yeah, that's why your potassium goes up by so much. Cool. So when muscles break down, you see CK and potassium. You'll see other things too, but those are oftentimes just a product of like downstream problems. Like your creatinine will go up because of myoglobinuria. All right, so this is the story, right? So as Deb pointed out, creatine kinase should only be inside the muscle and should be inside the cell, not in your bloodstream. So if we have something like rhabdo and our muscle breaks down, then we're going to have a bunch of potassium, right? Because our potassium is really high in the muscle, and we're going to have the creatinine, the creatine kinase also get into a bloodstream, and we will be able to detect it on a blood draw, right? Because normally you shouldn't see such high potassium levels because most of it's in your muscle, and normally we shouldn't see creatine kinase because it should be inside your muscle, not outside of it. So Mohana, so what do the kidneys control, or how do the kidneys control the amount of substances in our blood, like in a general sense?
The kidney control the substance by reabsorbing or secreting into the urine.
Exactly. And in addition to that, it filters, right? So some things are filtered, some are not, right? Some things are secreted, some are not. Some things are reabsorbed, some are not, right? And you can titrate the amount of secretion and reabsorption. It's pretty amazing, pretty amazing. So Boogie's asking, Paul's asking, would you also see elevated calcium? Probably not, because again, the majority of the calcium, like there's like a 40-fold difference between intracellular potassium and extracellular potassium, which is roughly the same for like sodium. It's like a 400-fold difference. It's like an order of magnitude difference for calcium, because most of the calcium's outside of the cell, it's not inside. So if you get rhabdo, you shouldn't see high calcium. Yeah, it doesn't. Your calcium's already outside the cells. So breaking down muscles, there's not a lot of, I guess there's some, right? Because there's the sarcoplasm reticulum, but not as much as is outside. So I don't think so. I don't think you see a really high calcium. But he's asking, would you see a spike in potassium as well in an MI, or only CKMB? You might see a little bit, but remember, like your heart muscle, in terms of the number of cells, the amount of potassium that's like inside your heart is probably not that much overall, right? If 78% of all of your potassium is inside your muscle represents only, I don't know, a fraction of all the muscle in your body. So if it was a really massive MI and took out your entire heart, maybe, but then you'd have a lot more problems than just your spike in potassium. So probably not. Yeah, I think it'd mainly be CKMB. Okay, but yeah, so kidneys control the amount of substances by filtration, secretion, and reabsorption. So filtration. So Nathan, like, how do the kidneys filter? What do they filter through?
Like Bowman space?
Yeah, exactly. Well, it filters it to Bowman space, but it's through the glomerulus, right? Your glomerulus is basically like a sieve. That's what I'm going to argue. It's a lot easier just to think about it as a sieve. So Nitin, where are the things filtering from? Nathan's already kind of answered the second part, right? Where are they filtered to? So where are they coming from, and where are you going to filter them to?
So they are filtered from the afferent arteriole and to the efferent arteriole. Loop of the proximal convoluted tubule, loop of Henle, DCT.
Sure, but before it gets to the proximal convoluted tubule, where does it go?
Glomerulus.
Yeah, what's through the glomerulus? It goes actually technically.
Okay, yeah.
The afferent arteriole isn't really where it's being filtered from. Technically, it's coming from the capillary, but you're right in that like the capillary blood is coming from the afferent arteriole. But I want you to think of what is immediately before the glomerulus and what is immediately afterwards. It's the exercise that I wanted. So basically, you can think about this is that you've got your sieve, right? Your little mesh, which is your glomerular basement membrane. And before it, you got the glomerulocapillary, and after it, you got Bowman space. Pretty much it. Paul, can you tell us what determines what things are filtered through the glomerulus? Like generally, what are the things that'll determine whether something gets filtered or not? What do you think, Paul? Oh, Paul answered. He said, the charges associated with the molecules and size. Very good. Yeah, exactly. It's basically charge and size. That's it. So things that are smaller, more easily be filtered through. Things that are uncharged, certainly. I think it's positive things get through easier than negatives. Because I think that's like how albumin gets filtered out, is that I think it's negative charge. But yeah, it's charge and size. So Paula, is creatinine filtered through?
Oh, I want to say no because of its charge. The charge?
It is uncharged.
Oh, but then because of its size.
So creatinine is filtered through.
Okay. Oh, it's not reabsorbed.
Correct. Yes, that is a critical point. Yes, it will make it through. So creatinine will make it through to Bowman space. If it didn't, it would be useless to us, and it would just accumulate in our blood, and we would just be full of creatinine. Yeah. So how about protein? Paula, is protein filtered through?
Protein is not.
Very good. Yeah, generally it's not. Right. So if I've got protein, generally speaking, it does not filter through the glomerulus. So creatinine makes it through. I pee out creatinine, but I normally, right, outside of nephrotic syndrome or certain kidney problems, shouldn't be peeing out protein because it shouldn't be filtered through. should stay in the blood. Cool, makes sense? Because what we're building towards is the idea of why does creatinine increase when you have kidney failure? This is it, basically, because it doesn't get filtered. That's going to be the punchline. So just to give you an idea of what we're building towards. Okay, so Priyanka, generally speaking, what is filtered through the kidney?
Is this talking about like after the glomerulus?
Yeah.
Or just
That's a bad question. That like
sorry.
It's basically
Sorry, I
it's
just
like a
really
read-memory
like
question.
this
So
idea.
let me give you
Why-
another question. Basically, it's most things except for protein, generally speaking. So what are the things that we would want to keep that are filtered through the glomerulus, right? There are some things that we want, right? Like we need sodium, we want potassium. How do we make sure that we don't lose it? Because those things get filtered through.
Would that be with our like the channels that are in the proximal?
Sure, but in a general sense, what are those channels in the proximal tubule doing?
They're reabsorbing.
Yeah, exactly. It sounds pretty simple, and it is very simple, right? If I filter something, but I still want it, I need it, right? I'm like, I need that sodium, give it back. So I reabsorb it. I'm like, oh, I need that potassium, give it back. You reabsorb it because you end up, so let's say that you had 100, if you're gonna filter 100 molecules of sodium, right? Priyanka, how many of them are you gonna reabsorb?
Not all of it, but I know like most of it. I'm not sure exactly how much it was.
60%, 70%, 80, 90, 99, what?
I would say most of it, so probably like 80.
It's like 99.
I'm totally guessing.
99%. Yeah, 99%. The way to know that is that it's the opposite of FeNA. We'll talk about this later, but it's the opposite of FeNA, right? So FeNA, right, is how of all the stuff that's filtered through, how much is lost, how much is the fractional excretion of sodium, how much is lost. So if the FeNA is 1%, means I've reabsorbed 99% and I've lost 1%. That's pretty normal, FeNA of 1%. So yeah, most of it. So if I filter something through and I still want it, I need to reabsorb it. And we reabsorb a ton of stuff. The kidneys are pretty brilliant. So Sujith, why would we want to secrete things? Why would that make sense?
Maybe there's some excess that's not in body, so just kind of
Exactly. Like in a general sense, I reabsorb things because I want to keep it. I secrete things if I don't want it. Pretty simple. But exactly what you said. Yeah, maybe I've got a little bit too much. I need to get rid of it. Yeah, totally. So let's talk about glucose as an example, right? So Susanna, I want you to tell me, based on the size and charge of glucose, is it filtered? And if so, what happens next? Or if it's not, what happens next?
Oh, yeah, I think it's filtered until at the extent when it saturates the transporters, then it's not filtered normally, sorry. And then when it saturates the transporter, it's filtered but not, I don't know, I'm confused about myself. No, it's not filtered until it saturates the transporters. Oh, that was like sorry, it's filtered, but it's okay. It's filtered, but it's not reabsorbed. It's reabsorbed until it saturates like all the transporters. Then it's not reabsorbed anymore, and you can find it in the urine. I think so. Sorry.
Yeah, so that was good. So it felt like putting you on the spot made it so that it was harder to integrate that knowledge. Like you had some factual knowledge, but it was harder to use it. Right?
Yeah, I was like, okay, what do I say?
It's something, but like this is bolded because I want you to make a part of this. So it's small and it's uncharged, so it's filtered. However, we want to keep it, right? If we lost all of our glucose in our urine, that would be pretty bad. It'd be pretty hypoglycemic. So we have to reabsorb it. So I've got my glomerulus, right? Represented by my sieve, right? By my mesh. And so I got glucose. It's going to go. And it filters through, right? Because it's uncharged and it's small. So it's going to go to the proximal tubule. And then in the proximal tubule gets reabsorbed. So what Susanna was talking about was that if I have too much glucose, right? If my blood glucose is too high, then what ends up happening is that I have so much glucose that it's going to saturate these transporters. I cannot reabsorb all of it. Therefore, some of it is going to stay in my urine, which is why my urine is going to taste sweet, which is why they call it diabetes mellitus. It's because in the olden days, they would taste people's urine. And because mel is honey in Greek, so they taste it. My daughter has this funny book. It's like not an encyclopedia. No, it's like essentially like a kid's encyclopedia for 4-year-olds. And it has like this really funny picture of like old people, like picture of people tasting urine. She's like, ew, that's gross. That's what you did. So that's why it's called diabetes insipidus, right? Diabetes is like you urinate a lot. And then insipidus insipid means like tasteless. So it doesn't taste like sweet. So it's tasteless. So they call it diabetes insipidus. As opposed to diabetes mellitus, right? Mel is honey. And so that's why they call it diabetes mellitus, because you've saturated those transporters. That's why when, the guy that discovered insulin, right, the way that he figured it out, or one of as the story goes, is that like his dog that he'd taken out the pancreas in, he noticed that there were a bunch of flies hanging around the urine because the urine was sweet. So cool, yeah. So this is the parts of the kidney that reabsorb different things and what they reabsorb. So let's go back to Alexa. And Alexa, can you tell us, where does the majority of reabsorption happen along the nephron? Just like in general. And then use this to explain what area is most sensitive to ischemia. Because we want to integrate it, right? We don't want to just memorize it, we want to integrate it.
Yeah, so the majority of the reabsorption is going to happen at the proximal convoluted tubule. And because the PC2 is doing most of the work, it's the most vulnerable to ischemia.
Yeah, exactly. So the proximal tubule, right? So if they ever ask you, this is a not uncommon question on board exams, is the vast majority, or I'll say something like, most of X is absorbed where, right? Or something like that. If you guess the proximal tubule, you'll be right. I don't know, probably 95% of the time. Like, it's almost always right. That's almost always the right answer. And so it's important to know this for a couple of reasons. But one of them is that because so much stuff is reabsorbed in the proximal tubule, like even though sodium is absorbed, right, like at various places along the nephron, still the majority of sodium is still absorbed. Right? So this is important because it's very ATP dependent, because there's a ton of sodium potassium ATPases. So it needs lots of ATP. So it needs a constant supply of glucose. And so, right, it has glycogen. Actually, the reason why we have like clear cell carcinoma, like renal cell carcinoma, it's usually of the proximal tubule, or oftentimes it's of the proximal tubule. And it's clear because there's so much glycogen in fat, right? Because they just have such high energy requirements. And so if you have cancer of those cells, again, it's the same thing. You're going to have cancer cells that also have a lot of glycogen and fat. And so they're clear because when you dissolve all this stuff in this slide prep, glycogen and fat wash away. And so it looks white. It's white. But yeah, there's so many integrations that like of this concept, including that when you get ischemic ATN, which we'll talk about later, when you get ischemic ATN, you see the casts in the proximal tubule first, right? Because again, it's most susceptible to ischemia. And so when you have the ischemia and the cells slough off, they block the proximal tubule first. Cool, isn't that cool? All right, I thought that was really cool. Okay, so let us go to Boogie. And Boogie, can you please tell us, what are the three major parts of an amino acid, generally speaking?
I thought it was the amine group and the phosphate group and then the rest.
It's not a phosphate group, pretty close. So it's just think about the name, right? Like biochemistry.
Oh, sorry, carboxylic acid, sorry.
Right? It's the amino, right? So it's amine group, right? Acid group. And then there's the R group, right? The R group, the thing that's attached to this carbon. That's it. So Danielle, when you break down an amino acid, what waste product must you eliminate? Sort of a read my mind question, but it's important.
Nitrogen?
Yeah, exactly. You gotta get rid of that nitrogen, specifically the ammonia that forms NH3, which can form ammonia. So Deb, why is ammonia bad for your body? Why is it so bad?
I know that ammonia accumulated in the body, it might get hepatic encephalopathy.
Good, right? So in other words, it can cause problems in your brain, right? Hepatic encephalopathy means that there's a problem with your liver. And specifically in that case, it's because you can't turn ammonia into urea, which we'll talk about next. But so the ammonia accumulates, goes to your brain, causes brain problems. But the question is why? Most people don't know this. So among other things, it inhibits the TCA cycle and decreases ATP production. To be honest, this should probably be one of those questions that you know, because this does show up on exams, particularly step 1. So let's talk about why. So it inhibits the ATP production. So let's talk about why that is. Okay, so this is a simplified version of the TCA cycle, right? So remember TCA cycle, the whole purpose of the TCA cycle is to take acetyl-CoA, which just about everything when it breaks down goes into acetyl-CoA, like fatty acids become acetyl-CoA, ketone bodies become acetyl-CoA, ketogenic amino acids become acetyl-CoA, like lots of things become acetyl-CoA, including pyruvate and glucose. And so it turns acetyl-CoA into NADH, 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 and FADH2. And then you get one GTP. For more, I would go to the biochemistry lectures, but that'll suffice for now. What you need to know about ammonia is that if I add ammonia to certain things in the TCA cycle, I will actually form a different product. So if I add ammonia to alpha-ketoglutarate, I will make glutamate. And if I add ammonia to oxaloacetate, I will make, you guys know, aspartate. And if I add ammonia to pyruvate, do you guys know? Alanine. Right. So these are things that you have to know, actually. These are biochemistry questions if you're studying for step 1. These are things that you have to know. Although I would say, generally speaking, I think anyone should know, regardless of what exam you're studying for, why ammonia is bad for you. Right? Because in a general sense, it will shut down your TCA cycle and thus compromise, right? Decrease your ATP production. That's not good. But it also explains why you feel so bad, like your brain feels so bad, right? Why you feel so slow, lethargic, because it's literally depleting your brain of energy from the inside. Cool. All right. So questions so far? So we've talked about urea, and we're about to talk about urea, right? But we talked about ammonia. So what we'll talk about next is how we eliminate ammonia as urea. We talked about creatinine and why it's filtered because it's small and it's uncharged, and so it'll filter, which is why when you have kidney failure and you have decrease in filtration, you'll have an increase in creatinine. All of these things are important. Cool. Okay, so what is urea? So Jared, what's the purpose of urea?
Urea, isn't it like what you dissolve the ammonia in to get it through the nonpolar barrier?
Oh, interesting. The terminology is it's probably not technically correct, but I think I get what you're saying. Right. So basically, it's a way to eliminate the amine group when you break down an amino acid. It's not really dissolving it. You put literally the NH2 from the amino acid into urea. That's what it is. Like, this is urea. So these NH2 molecules come from the amino acids. It's not really dissolving it per se, but you're adding the amine groups to a carbon, and you can eliminate this urea. So you can get rid of 2 NH2s per urea. And so you can use its chemical structure, as we just talked about, to explain the purpose, because it has 2 NH2 groups. And so each of those NH2 groups came from a different amino acid. And so this is how you can eliminate it. Because otherwise, the alternative would be, as Jared said, you just have a bunch of amine groups, right? You just have a bunch of ammonia running around, and that would cause havoc for your brain, which is exactly why you get hepatic encephalopathy. Because you can't make urea, right? Because urea is made in your liver. So the ammonia is just going to accumulate and shut down the TCA cycle in your brain. Cool. Make sense? Okay. Yeah, because these are the main groups, basically. Okay, so reabsorption of urea. So Mohana, urea, use its size and charge to explain whether it's filtered through the glomerulus, and then tell us what happens next.
Oh, I'm not really sure about this, but I'm thinking.
Is it filtered?
Yes, it is.
So if it's filtered, what would you guess the size is?
It's smaller than the.
Yeah, exactly. It's got to be small enough to be filtered. So yeah, it's reasonably small. Good. And so I think it's also uncharged. Well, yeah. I mean, again, it's going to depend on the environment, but generally speaking, it's probably going to be uncharged based on the chemical structure. Okay.
Yeah.
And so the question is what happens next? And this is important. So what happens next is that it is, in some cases, it is actually reabsorbed, but it is reabsorbed. Okay. So that's important. So this is our urea, right? So again, glomerulus, which is basically a filter. We have urea here that's made from the liver, takes ammonia, and then urea is going to filter through. It's going to go. As long as ADH is high, right? So ADH is the signal. So if ADH is high, it gets reabsorbed. Cool. So ADH high, your reabsorption.
So is it reabsorbed to maintain the medullary osmolarity?
No, I don't think so. Your medullary osmolarity, we'll talk about this in not next lesson, but the lesson after that. Your medullary osmolarity is maintained by the lubricant, specifically the sodium potassium ATPase. The sodium potassium 2 chloride channel. Sodium potassium trichloride channel, which depends on the sodium potassium ATPase, but really it's the sodium potassium.
So the urea doesn't play a role in the medullary osmolarity?
I don't think so. Is urea absorbed in any other place? Maybe it is.
I thought it was also reabsorbed in the collecting duct.
So it is in the collecting duct. It is reabsorbed in the collecting duct, and it looks like, I didn't know this, but it's secreted into the lubricant. So I think though that the majority is from this. So I don't think that then it could water and urea. I don't think so. Maybe if you could have urea only, maybe it could right here, it can contribute to your interstitial osmolarity. If you only reabsorbed urea and you didn't reabsorb water, maybe. I actually didn't know that. I don't know. But if it does, I think it's going to have a pretty small effect. Actually, no, I don't know. Someone look that up. I'm going to guess probably that's not going to have much of an effect, honestly. But I could be totally wrong. But you don't need to understand urea to understand like why your interstitial why the interstitial osmolarity is high. The only one that you really need to understand for countercurrent multiplication and interstitial osmolarity is the sodium, potassium, G-chloride channel, which we'll talk about not next lesson, but the lesson after. Cool. So Nathan, so we are constantly making creatinine, right? Because it's a breakdown product of our serum creatine, which creatine is a reservoir for our high energy phosphate bonds in muscles to help cock our myosin heads so that when it can bind to the actin. Okay. So why doesn't the level just continue to rise in our blood? Because we're constantly making it. So why doesn't it go up?
I think because it's a secreted product. Like it gets secreted in the kidney.
So let's be very careful. So there's 3 ways that your kidneys can affect a substance. It can either secrete it, it can reabsorb it, or it can filter it. So this is really important because it's repeated a lot in textbooks, and it's one of those things that I just memorized for the longest time. I hadn't really thought about why it was important. But which is it that creatinine does? Is it filtered? Is it secreted or reabsorbed? What's the main thing that it does? Because technically it's
probably filtered.
Great, exactly. It is filtered. So they say, right? Well, so because it's filtered, why would that mean that the level wouldn't just continue to rise?
Could you repeat the question? Sorry.
Because our question is, why doesn't the level of creatinine continue to rise in our blood? So you said filtration, but like, just walk me through. What does that mean? Why would filtration mean that the level wouldn't just continue to rise?
I guess it's the rate of filtration.
Essentially, sorry, that was a read my mind question. That was a bad question. Basically, the idea is that, right, the rate at which we make creatinine is balanced by the amount that's eliminated, right? So the reason why we reach a steady state is because the amount of creatinine that we create at any given time should equal, roughly, the amount of creatinine that's eliminated via the kidneys via filtration. Cool. That makes sense? So that's what we mean when we see a steady state, right? Amount in equals the amount out. So the idea, right? So we've got our muscles, right? Now it's a little bit more complicated diagram, but we've got muscles that are going to make creatinine. It's going to go into the bloodstream just like it did before. And so it's going to be filtered through. It's going to make its way all the way through the nephron, and it's going to be peed out. And so the idea is that the amount that we make is going to roughly equal the amount that we are eliminating via the nephron, such that, right, the amount that's in our blood is, right, that like the amount that we eliminate is equal to the amount that we produce. That's it, right? So we always have a little bit of creatinine in our blood. Cool. All right, so Nitin. So like SHOP, organ failure is typically poorly understood by med students, but it does not have to be. So when we say organ failure, really it just means the failure of the organ to do what its key function or functions are. And so what are the key functions of the heart, basically?
Pump the blood to exchange oxygen and
pump blood to the body, pump blood to the heart, or sorry, pump blood to the lungs, or pump blood to the body. Pretty much it.
Yeah.
So based on that, how could you explain what heart failure is based on its function?
So it's the inability of the heart to pump adequate blood to meet the body's needs.
Yeah, exactly. Yeah. So heart failure just means the inability to provide blood to the body. Or you need abnormally high filtration. Pretty simple. Paul, what are the key functions of the lungs? I think Paul might not be able to speak. So it's 2, you need to oxygenate the blood and you need to get rid of CO2. So oxygenation and ventilation. Perfect. That's exactly what you wrote. Yeah. And so then Paula, based on your knowledge of the function of the lungs, tell us what respiratory failure means. What does that mean? What are the kinds of respiratory failure you can have?
So would that involve hypoxia as well as hypercapnia?
Well, it's not and, it's an
or. Okay.
It could be both. It's either. Yeah. So you can have oxygenation failure, right? So hypoxemia, your oxygen's too low, or you can have ventilatory failure, which means your CO2 is too high. It really is that simple. Like I used to get so flustered by like these concepts of what exactly is the definition of heart failure or respiratory. Like I would throw out these terms and I'd think maybe I was right some of the time, but really it's quite simple. Just think of what are the key functions. But yeah, so when you intubate someone for, you have to define like, was it because of ventilatory failure? Was it because of oxygenation failure? Was it because of airway protection? That's it. So Priyanka, what's considered the key function of the kidneys, at least in terms of what we're following? What's like the one really key function?
Would be just reabsorption?
That's not what we're measuring, actually. You got 2 other choices.
What did you say right before?
So it's not reabsorption. You have 2 other things that it could be. It's filtration, reabsorption, or secretion. So what's the key function that we measure, that we follow for the kidneys?
Oh, it'd be filtration.
Yeah, it's filtration. Very good. This is why we measure GFR. What does GFR stand for?
Filtration rate.
Yeah, exactly. It's not glomerular reabsorption rate. It's glomerular filtration rate. And that's why also we measure serum creatinine. So Sujith, tell me the key function of the kidneys to explain what kidney failure means.
There's a failure to filter and excrete or reabsorb the vital substances?
You had me at filter. That was really all you needed, right? That's it, right? It's just filtration, right? When the filtration is too low, that's essentially what we define as kidney failure, right? So if you think about like the stages of CKD, right? Your estimated GFR, it's just like a number. What's the number? Technically, stage 1 is when you have like normal filtration, normal GFR, but like other problems. So technically, it's closer to it. Technically, I think you're right. But essentially, right, for practical purposes, we mainly define kidney failure as a problem with filtration. So technically, you're right. Like technically, there's other things like proteinuria and things like that. I think technically those fit into stage 1. But most of kidney failure is defined based on your GFR. In other words, by filtration. Okay, so Susanna, so use the definition of kidney failure to explain what would happen to the serum creatinine concentration.
So it will decrease because
It'll decrease or
we're not
increase?
like- Sorry?
I couldn't hear it. Did you say the serum creatinine should increase or the serum creatinine should decrease?
Well, so we're like, since creatinine is like freely filtered, we're not filtrating, so it will probably increase in the blood, but then decrease in the urine.
Perfect. But what do we measure when we measure someone's blood?
The creatinine clearance.
Sure. Sorry, that's a bad, yeah. So you're saying the creatinine clearance would decrease, but the serum. So what I'm asking is what the serum creatinine concentration this is an important lesson to learn about reading questions. You have to read exactly what we're asking, not what you think that I'm asking.
So you're asking like what will happen to the creatinine concentration in the urine?
Okay. Again, this is a very important lesson that I want you to learn. Read the question again and tell me what I'm asking.
You're asking like this, what will be the concentration of creatinine if we don't have like filtration working anymore? Basically, that's what I'm getting.
Yeah, but I'm asking what's the concentration where?
Sorry?
The concentration of creatinine where? In your blood or your urine or right in space where?
I think that would be in the blood.
Yeah, great. How do you know it's in the blood?
Well, just like with the word serum, it tells me that it's in the blood.
Yeah, exactly. Yeah. Serum is the acellular portion of your blood, the non-cell portion of your blood. Good. Yeah. Exactly. Great. Okay. So I know I don't want you to. Well, you can think I'm mean. That's okay. But as long as you understand the point of me being like I don't know nitpicky, the thing that I realize, and I wish I could show you guys a question to demonstrate this. The thing that you'll see is that oftentimes you're gonna miss questions because you read something too quickly, or usually as a consequence of reading it too quickly, you don't actually understand what the question's asking you. You kind of assume, right? Because in your case. I think, Susanna, what you were doing is you were thinking, okay, well, like the concentration in the urine is going to be decreased because of decrease in filtration. But that's not the question I was asking you. So if you answer the question based on what you were thinking, you're going to get that question wrong. And in this case, it doesn't matter because you can clarify. Sorry?
Yeah, I agree. I just read it too fast, and then I was like, oh, okay.
Totally. But this is exactly what happens in tests. I see this a lot. And I'm sure you guys, if you go back and you really look at why you miss questions, I'm going to guess that, I don't know, 25%, 20% of the questions, you're missing because you don't actually understand what they're asking you. You're going to go back and you're going to read the question and be like, what? Oh, that's what they're saying? Oh man. And then maybe 20 or 30% of the questions you're going to miss because you read the vignette too quickly. You read the actual, the thing preceding the question too quickly. But yeah, it's amazing because it says serum creatinine concentration, but it's really easy to think like just to jump to a conclusion and think, oh, I'm talking about urine. But you're right. So kidney failure is defined as a decreased GFR below a certain threshold. So creatinine is constantly made as a breakdown product of muscle creatine, right, which is the high energy phosphate carrier for muscle. So when the substances like creatinine can't be filtered, they're going to accumulate in the blood, which means the serum concentration is going to increase. So, right, we've got our nephron, we've got our glomerular basement membrane, which is this. So we're going to make our creatinine in our muscles, breakdown product of creatine, turns into creatinine, goes, and then if I have a kidney failure, it's not going to be filtered. So it's not going to go into my kidneys. So it's just going to accumulate. So instead of it being eliminated and going all the way out and eliminated, my creatinine is just going to be constantly made and it's just going to be constantly accumulating because I cannot filter it. Because creatinine is freely filtered, neither reabsorbed or, well, it's secreted technically, I think a little bit. But essentially it's freely filtered and that's it. Not reabsorbed or secreted to significant amounts. So Shama, oh man, I already told you the answer to this. So creatinine levels are used as a general measure of kidney function. So what special property of creatinine allows for this?
Yeah, you just said it, but already know that it just has to do with filtration, right? So if it's elevated, you know that there's a problem with the GFR elevating the serum.
Perfect. Yeah. Because it's virtually no secretion or absorption. So why did it matter though? Shama, explain to me why that matters.
Why it matters is that the kidneys aren't functioning. So we need to evaluate basically what is wrong with the functioning of the kidneys. Is it a pre-renal injury to the kidneys, as in
No, sorry. I'm asking why does it matter if creatinine is freely filtered but not secreted or reabsorbed?
Oh, because it's kind of like a constant in physics. Like it shouldn't ever be altered. Like if it was secreted, that means that there's active like secretion by the kidney to make it happen. If it's reabsorbed, then it's actively reabsorbed by the kidney, but filtration is occurring like passively.
Yeah, perfect. Yeah, so Deacon says it's an indirect measure of GFR. Exactly. Yeah, it's a way to estimate the GFR. So remember, kidney function is largely defined as the ability to filter, essentially, right? So if there's a problem with filtration, creatinine levels are going to rise proportionally. So creatinine levels can be used as an indirect measure of kidney function. That's why we use it as a measure of GFR. Great. Let's talk about MUN. So Alexa, so use the definition of kidney failure to explain what would happen to the BUN concentration.
So BUN is blood urea nitrogen. So in kidney failure, you're not able to excrete the urea. So that way you're going to have an increase in the nitrogen or the urea content in your blood.
Perfect. Exactly. Yeah. So again, same explanation as with creatinine, right? So you're right. And this time, instead of it being the muscle, it's the liver, right? The liver turns ammonia into urea, which is why in liver failure you have high ammonia. Right? And so your urea is going to go to your kidneys, but instead of making it through, it's just going to bounce off because it can't filter. Probably not going to bounce off. It's just not going to filter for whatever reason. And so it's just going to accumulate, just like creatinine accumulates because it doesn't filter. And so you can't eliminate it. So it's just going to accumulate in the blood, just like the creatinine does. Cool? Make sense? All right. So Boogie, so how much of the body's weight is water?
Around 70% of our mass is water, right?
Almost. It's about 60%, but pretty close. So Shama, how much of this is extracellular versus intracellular?
I forgot, but I think it's about 10 or 15% intracellular, but there's definitely more extracellular.
It's actually the opposite. There's actually more intracellular than extracellular.
Okay.
Trying to think of how we could twice as much as intracellular as extracellular.
Well, then you could just think of it like alphabetically.
I guess so. I mean, like, but think about like, I guess it's maybe a little hard to justify, but think of how much stuff you have dissolved in your body, right? Everything is your intracellular and extracellular space is isotonic, right? So do you think you have more things dissolved inside of cells, like where all the enzymes and everything are? Or do you think you have more things dissolved outside of cells?
I would say inside.
Yeah, I mean, like your body functions like the intracellular portions do stuff, basically. The function of all of your organs is intracellular. So it would make sense that you'd have more stuff dissolved inside of cells than outside. So in order to maintain, because again, the osmolarity of everywhere in your body is the exact same, except for the renal medulla, basically. But everything else is isotonic, everything else. So if I have more stuff dissolved inside of my cells, I have to have more water inside the cell. So Danielle, of the extracellular water, how much of it is inside blood vessels versus outside the blood vessels? Danielle, what do you think? Or how about Deb, what do you think? Do you happen to know of the 1/3 of all the total body water, how much of it is going to be intravascular, right, inside the blood versus extravascular, meaning in the interstitium?
The interstitial 2/3 of the ECF, and the plasma will be 2/3 of the ECF.
Almost. So it's about 1/4 to 3/4. So 1/4 of your extracellular fluid is ECF, and about 3/4 is interstitial fluid. Okay. So we're gonna talk about why it's important, but Jared, so why is sodium so important broadly? There's two very broad, somewhat mind-reading kind of answers. So I'll be impressed if you can get that.
I think the first one might be my bio teacher always said like water follows salt, so like water would follow wherever more sodium goes.
Great. So specifically, it determines your extracellular fluid volume. Great. That is one of the reasons.
And the second would be maybe it's important for neuronal transport.
Exactly. Yeah. So the concentration gradient across the cell membrane is the basis for all action potentials. Just about. Not every single one, but just about. And the serum sodium concentration also determines the extracellular fluid volume. Water follows salt. And because the sodium potassium ATPase excludes sodium, it's going to be outside of cells. So it will determine the extracellular fluid volume. It's the dominant ion. So Lahana, use sodium size and relative importance to explain whether it is filtered, secreted, and or
So sodium is really filtered and also reabsorbed at the proximal tubule as well as DCT.
Yeah, it's like you're just absorbed like almost everywhere, right? All those like diuretics come into play. So it's small. It is charged, but it's small. So it's filtered through. So it's hugely important to the body. So you reabsorb just more than 99% of it most of the time. Great. So let's talk about briefly, right? So this is a pictorial representation of, or diagrammatic representation of the total body water, right? So we said 2/3 is ICF, 1/3 is ECF, and then 1/4 is plasma, and 3/4 is interstitial. So Nathan, we said what ion is the largest determinant of extracellular fluid volume, and why is this?
Sodium?
Yep, and why?
Like sheer quantity, like 140
Yeah, yeah, sorry, that's a bad question. What I'm trying to get you to recognize is that sodium is excluded from cells, right? And the reason that it's excluded from cells is because of the sodium potassium ATPase. The sodium potassium ATPase excludes it from the inside of the cell and makes it go to the outside of it. Okay. So I'm going to go through a little bit faster because I want to make sure that we get to the question by the end of this. And so for the sodium potassium ATPase, the number of ions that are moved is that you'll have 3 sodiums that are moved out and 2 potassium that are moved in. And so the reason, so Nitin, why do you see cell swelling as a sign of reversible cell ischemia? Why would that make sense?
So in terms of cell swelling, the sodium potassium ATPase pump is disturbed. So now 3 sodium will not be able to go outside the way it should be, and it will increase inside, and it will pull more water inside because the direct sodium pulls the water inside.
And the key to recognize is that there's more sodium moving out than there is potassium. So the sodium potassium ATPase should, right, on net, cause more ions to move out than if you lose that, then you'll have more ions accumulate in than out. Yeah, the sodium determines your ACF. So sodium, because of the sodium potassium ATPase, is going to accumulate in the extracellular fluid because you have the sodium potassium ATPase is going to kick it out. The ICF. Oh. So yeah, so sodium, if I increase my sodium, really I'm going to mainly increase my ACF, which means I'm going to increase my plasma and my interstitial volume, but my ICF is largely unchanged. Okay, so in terms of kidney failure, our sodium, right? Our sodium should do what, Paula? So Paula, what's happened to our total body sodium? Sorry, what would happen to our blood pressure in kidney failure?
In kidney failure, so you would be losing, you wouldn't be able to reabsorb sodium as much, and hence you would lose the sodium, and you would.
But so that's true, but the bigger problem is that you have a problem with filtration.
Oh, okay. So you wouldn't be able to excrete the sodium, you would retain it, and you would get like fluid overload and hence like hypertension.
Exactly. So sodium accumulates because you can't filter it. So outside of the reabsorption part, right, if you can't even filter it, the reabsorption doesn't matter. So yeah, so typically in people with chronic kidney disease, you will see an increase in their blood pressure in large part because you have an accumulation of fluid. And so you will often see this. So in the blood, sodium is going to come and then it can't be filtered. So it's just going to accumulate. And so the more sodium you have, the larger the blood volume. Because again, sodium accumulates in extracellular fluid where your blood is, and that's going to increase your blood pressure. So it's just going to keep increasing until, your blood pressure is just going to increase. Okay. So your concentration, though, of sodium should be unchanged. Because again, I think Jared or Nathan said that your water follows salt. And so because water is retained with sodium, the concentration is unchanged, even though the total number of sodium molecules in the extracellular fluid has increased. So again, because sodium and water are both increased, it's going to increase, right? It's going to increase the blood volume, right? But the actual proportion of sodium to water isn't changed. So the total concentration of sodium is the same. Okay, great. So now we are back to our vignette. So I want you to go to the session document and we can revise what we had written previously. Cool. For a couple minutes. Okay, so let's look at your guys's. All right, so Danielle. So chronic untreated hypertension leads to atherosclerosis. Sure, I guess it could lead to renal artery stenosis, but mainly it's just going to cause kidney failure. And so, GFR is decreased filtration, increased creatinine, urea, or filtration, normal sodium concentration, right? So you can still be absorbed and secrete enough. Yeah, that's good. That's good basic. Let's look at Sujith. So normal birth, good. Develops hypertension unmonitored, so increased pressure in the renal arteries. Yeah, so it could be renal artery stenosis, but the most likely scenario is it just caused like kidney failure. And so decrease in GFR, failure, it's not really acute, probably not acute. So yeah, ultimately leads to chronic renal failure. and then increased serum creatinine and BUN and serum sodium. So I would say, yeah, so serum sodium is normal, serum concentration is normal, but the intravascular fluid is up. Good, perfect. So Alexa, I'm still a little confused as to what you mean by relating the serum creatinine with his blood pressure. Oh, so in other words, what I'm asking is, you want to explain why is his blood pressure, why is his blood pressure high? And what I want you to recognize is that particularly in chronic kidney disease, what you'll often find is that the blood pressure is high. And one explanation would be that high blood pressure leads to kidney failure. But another thing that does happen is that in kidney failure, because of the accumulation of sodium and thus extracellular fluid volume, you will have an increase in blood pressure as a consequence to that. Does that make sense, Alexa?
Yeah, I think so basically by saying serum creatinine, that's a marker of kidney failure. That's what you're saying by that. Okay.
The serum creatinine itself is irrelevant.
Yeah, I get that now.
The point is that you're not filtering out with the sodium as well. And so the sodium retention is causing the fluid overload.
Okay, yeah, thank you.
Bowie's asking, if sodium is retained, how do we know that the sodium is not temporary due to the increased fluid load of the RAS? We're still losing sodium. Yeah, there's probably some contribution of RAS, right? Because RAS is activated by chloride to the macula densa. And so presumably if you have a decrease in filtration, you're also going to have a decrease in the amount of RAS. Decrease in the amount of chloride, which means you're going to increase your RAS. So yeah, presumably it's also not just because it's accumulation, but because you have RAS that's increased in a dysfunctional way.
It is also a function of aldosterone increase, which is precipitated by the increased BUN, correct, doctor?
That BUN increases aldosterone? Is that true? I didn't know that.
I thought we talked about the function of what's happening with the mechanism between increased urea specifically.
Oh,
and aldosterone.
ADH increases.
Oh, I'm sorry. Not aldosterone, but that as a function could also be contributing to our hypertension, correct, Alec?
So you're saying that kidney failure could lead to an increase in ADH? I mean, there might be some. Probably not. Probably. Maybe. I never really thought about that. So ADH, the primary function of ADH is to maintain serum osmolarity. So I guess in kidney failure, maybe you could think that there would be an increase in osms. There probably will be an increase in osms. So yeah, maybe there will be some increase in the ADH, maybe. But I don't even think it'll matter though, because you're not going to really be absorbed free water. If it's that bad that you're accumulating osms, you're probably not going to have the ability for ADH to even function. But good question. Okay, so the way that I want you to think about this is, again, so that we talked about the summary of the pathophysiological chronology. Again, I would just think about this as, okay, so you have chronic kidney failure. I wouldn't just, everyone that has hypertension that develop kidney failure, I wouldn't assume that they have renal artery stenosis, right? Probabilistically, it's probably just CKD, probably just kidney failure. Some fraction of those CKD patients will have renal artery stenosis, but it's probably not as many as Q-Bank suggests, because it's a pretty popular concept for Q-Banks. So kidney failure leads to decreased infiltration, and an accumulation of things that would normally be filtered is going to happen. So you'll have an increase in sodium, so your ECF volume is going to increase, your intravascular volume is going to increase, which will increase your blood pressure. And as we talked about, because creatinine and BUN are not being filtered, they will accumulate. And so that's why they're high. Cool. So again, this was an attempt for me to go through a basic question and walk through, again, even though it's pretty basic, there's still a lot of underlying concepts here that I think that most people are missing. I wanted to point out the blood pressure increase. And I wanted to point out, again, I wanted to make you think, why exactly is the BUN high? Why exactly is the creatinine high? And why is the sodium normal? The serum sodium concentration is normal. So that was the point. Okay, perfect. So next time, I hope you found this useful. Next time, we're going to build on this concept and talk more about how we can use these concepts to explain the different kinds of kidney failure. So stay tuned. What if you could walk into step one already knowing you'll pass? I've watched students transform from failing practice tests to comfortable passes in just 3 weeks. In my next video, I break down the exact 10-step framework that virtually guarantees you'll pass. Not through luck or grinding harder, but through a systematic approach that just works. Click here to watch how to virtually guarantee a step 1 pass and get the system now.